Dr. Vishal Dave. I am medical advisor at Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Synergy 19 webinar on the topic hysterectomy for benign gynecological conditions, guidelines and advances. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is President-elect, Bhopal OBGYN Society. She is founder president of ISOAP chapter of Bhopal. She is national executive member of ISAR. She is joint secretary come joint treasurer of MPIAG. She is coordinator of Foxy Infertility Committee. And also she is convener of this present Synergy series, as well as she was convener of Perfection series and Symbiosis series. Over to Dr. Monica Singh.
Thank you, Dr. Vishal Dave, and thank you, Team Intas, for giving us this platform. And today, at the outset, I would like to welcome Dr. Amey Purandare sir, who is today our guest of honor for the evening, and Dr. Aruna Suman madam, who is our special guest. Our chief guest, Dr. Aruna Kumar, will join shortly. Today's webinar is very special because we have collaborated with three eminent South Zone societies of Foxy, Kanchipuram OBGYN Society, under President Umayal Murugesan ma'am and S. Vijayalakshmi as secretary, Kurnool OBGYN Society under the leadership of Dr. S. Venkata Ramana president and V. Radhalakshmi as secretary, and Vijayawada OBGYN Society under President Tirupura Sundari Madam and Somlata Raparti as Secretary. We are honored to have amongst us very eminent dignitaries today to give blessings to the program. And I am thoroughly indebted that ICOG has granted 2 ICOG points to this program. And we also have this webinar, which will be going to YouTube, and it can be saved and seen on YouTube whenever the viewers want. This is our 19th episode, and let me just walk you shortly through the program. The program is consisting of 3 sessions. The first session is by Joint Director, Maternal Health, National Health Mission, Government of Madhya Pradesh, Dr. Archana Mishra. She will be giving us an insight on the regulations and guidelines for hysterectomy with special reference to benign cases. Dr. Priya Bhave, again Secretary, OBGYN Society of Bhopal, will be talking on advancements in hysterectomy with special reference to robotics. And then there will be a very vibrant panel discussion, which will be moderated by Professor and HOD of Gandhi Medical College, Bhopal, Dr. Shabana Sultan. Along with that, we have Professor Dr. Nishi Mitra from Ellen Medical College, Bhopal, and Assistant Professor and Coordinator of the show, Dr. Nandini Singh, to be the co-moderator. We have panelists drawn from all over India, and we have eminent chairpersons. So while Dr. Aruna Kumar Madam is joining, I think I will straight away first welcome and felicitate Dr. Amey Purandare sir. Sir, we are thoroughly we are very delighted and so grateful to you that you could spare so many precious moments of your busy schedule to attend this program and give us your blessings. And Dr. Amey C. Purandare is a very well-known figure in Foxy. He is consultant obstetrician and gynecologist at Purandare Hospital, KG Somaiya Medical College, Sir H.N. Reliance, Bhatia, Masina, and Mumbai Police Hospitals. He has held very important positions, Senior Vice President AMOGS at 24 to 26. He's also the President-elect of AMOGS. He is the Joint Treasurer of Foxy 25 to 27 and has been the Joint Secretary Foxy in 2019. Sir held the post of Chairperson Food, Drugs and Medico-Surgical Equipment Committee of Foxy in the years 2015 to 17. And he is Assistant Administrator Foxy Manyata Project on Quality Care in Safe Childbirth. He also held the post of Clinical Secretary of MOGS 2425 and Mentor Youth Council of MOGS. He is the member of the Medical Advisory Panel of FPI and Finance Officer FPI Mumbai. Also very active as a peer reviewer in Journal of Obstetrics and Gynae of India, popularly known as JOGI. I went through his awards, and there is a row of gold medals consisting of the A.E. Dastoor Gold Medal, Dr. B.N. Purandare Gold Medal, Prince of Wales Gold Medal, and C.G. Saraiya Gold Medal. He is also the proud recipient of Dr. Deena N. Patel Gold Medal, Shri Mohanlal Desai Gold Medal, Foxy Young Scientist Award in 1998, Best Resident Doctor Award as a pass out from St. G.S. Medical College in the year 2000. MOGS has awarded him Dr. R.H. Acharya Prize for Best Papers, Dr. Kamal Jain Prize for Best Thesis, Dr. R.D. Pandit Prize for Best Thesis, and Dr. C.G. Saraiya Traveling Fellowship, which is so much coveted, fellowship nowadays, and has been for so many years. And also the recipient of Foxy J and J Ethicon Traveling Fellowship in 2003, and Banuben Nanavati Scholarship for Overseas Studies in 2005. He has been awarded Dr. Duru Shah Best MOGS Managing Committee Member Award successively in the years 2008, 14, 18, 19, and 20, and MOGS Dr. Ganatra Charitable Medical Center Award for Improvement of Women's Health in 2017, MOGS Mrs. Shailaja and Mr. Narayan Pandit Award for Women Empowerment in 2024. He is also the proud recipient of Manyata Champion Award in 2018, Pride of Foxy Award in 2019, Foxy Future Award in 2020, and MOGS B for Stree Puraskar by the hands of Governor of Maharashtra in 2022. Sir, we are delighted to have you amongst us, and your achievements, I don't think any one person can have these achievements together. So it's like a very proud moment for us that you could be here as guest of honor.
Thank you, Dr. Monica, for those kind words and the kind introduction. First of all, I'd like to thank you very much for considering me to be a guest of honor for this very well organized and very apt webinar. I congratulate you on choosing such an important topic. This topic is very close to my heart because in 2019, when I was Joint Secretary under the leadership of Dr. Nandita Palshetkar, who was President Foxy, we did face a challenge when we had a lot of media regarding the unjudicious use of hysterectomies in the farmers in the state of Maharashtra. Foxy championed the cause, understood what was the problem, and came up with a position statement so that we could justify every hysterectomy that is performed. Subsequently, that was used as a template. It was drafted by Dr. Nandita Palshetkar, Dr. Jaideep Tank, and a large group of national experts who came together, put forward their points of wisdom, and we created a position statement. This was then used at the national and the regional level across India to come up with guidelines. I'm very happy that it is an essential part of one of your scientific lectures in today's program. I would also like to congratulate you for inviting the Kurnool Society, the Kanchipuram Society, and the Vijayawada Society, emphasizing that Foxy is a national fabric. We need to spread Foxy all over India so that we understand different points of view, both north, south, east, west, because each one will have a different point of view which may be relevant to our practice and we may not have thought about it. I would also like to put on record my sincere respects to the chief guest today, Dr. Archana Mishra, and my good friend who is a special guest. She is a special person, Dr. Aruna Suman from Hyderabad. I think she is going to now, with her new role in Foxy as chairperson, do a lot for the Foxians as well as Foxy and for the women of India. I also see Dr. Randhir Singh, and they say that behind every successful man, there is a woman standing. But I think with respect to Dr. Monica and Dr. Randhir, there is nobody front or behind. Both of them go hand in hand and are very much devoted in their commitment to the women of India and to Foxy.
Thank
Monica,
you,
I
Amar.
hope to
Thank you,
see-
Amar.
yeah, I hope to see you join the Foxy in a role, specified role very soon, as you will definitely, in my opinion, be a valuable asset to Foxy, both in its clinical activities, in its community reach, as well as in its policy making, both advocacy and dissemination. I also welcome all the other distinguished faculty, chairpersons, delegates to this very important webinar. Sir William Osler said that a good surgeon is one who knows how to operate. The better surgeon is one who knows when to operate. And the best surgeon is one who knows when not to operate. And this is what the principle of surgery should be, not only in the past, in the present, or even the years to come, where we have got now newer methods. We must use technology for our advantage, but at the same time, we should not forget that old is gold and use the correct technique and the correct route depending upon each individual patient. So once again, thank you very much. Congratulations, Dr. Monica, and keep up the good work. And I welcome all of you on behalf of Foxy for this very interesting and well-planned webinar. Thank you.
Thank you. Thank you very much, Dr. Ameya Purandare, sir, for that comprehensive review about how Foxy has always supported a cause and also been judgmental about the right things and forwarded that judgment and guideline to the government authorities in a way that they could reform and they could, do something for betterment of the women in India. And more of this will be spoken by Dr. Archana Mishra in her first lecture. So I still do not see Dr. Aruna Kumar at present. So we will wait for Madam. In the meantime, I will introduce our special guest. A special guest is someone, like Ameya sir said, who is very special. And I thought immediately, Dr. Aruna Suman, I've been trying to rope you for a couple of months now, but Madam was busy in her election and traveling and so many things, so many roles she has to shuffle in. But ultimately, she did say yes to me, and so she is a special guest for today. One thing I would like to mention about Madam is like she takes my calls like any time of the day and evening, even late evenings, bordering on midnight, and she has been always very pleasant, very supportive, almost like a mentor. So thank you, Aruna ma'am. A big congratulations to you for getting the
Thank you.
coveted chairperson of Foxy election victory, which
Thank
was very closely contested and very well taken by you, madam.
Thank
And
you.
I'd like to introduce you today as our Professor OBGYN and HOD of Vice Principal of Government Medical College, Jagtial, Telangana. She has been the Joint Secretary Foxy 2021 and the Organizing Secretary of the very well conducted and praised AICOG at Hyderabad in 2024 in that huge, beautiful venue. National Coordinator to No to Violence Against Women Committee, as well as very active member of Practical Obstetric Committee in 24-25. She has been South Zonal Coordinator of Foxy in 22-23, Adolescent Health Committee Foxy member in 16 to 18, Vice President OGSH 20-23, and TCOG Treasurer 22 to 20.
Thank you, Monica. We have good
Madam,
academics, so let us not
I
waste a
need
lot
to
of time.
for the awards, ma'am, because you have worked so closely. You have been one of the veterans of Foxy. So you have been the recipient of Dhira Award, Foxy Achievers Award, IFS Excellency Award, and Award for Excellency ISSRF. Madam, we are honored to have you amongst us today. I'd like to have blessings from you, madam.
Thank you, Monica. Thank you very much for the opportunity. Thank you, Randi sir. It's pleasure and it's my privilege
ma'am.
to be here to share the platform with Dr. Aruna Kumar, who is DME of Government of MP, and dear friend, who is a guest of honor, Dr. Ameya Purandare. He's very well organized, more disciplined and intelligent. We have so much to learn from him. Thank you so much for all the wishes Dr. Amaya, and my sincere thanks to Kanchipuram OBGY Society President Dr. Umayal Murugesan. Congratulations, Umayal. She's a very dear friend of mine, and Dr. Vijay Lakshmi, Secretary. Kurnool Society President Dr. Venkatramana Sir, and dear friend Dr. Radha Lakshmi, and all the best to you, Radha. And Vijayawada's OBGY Society, Dr. Tripura Sundari Ma'am, President, and Somlata Raparthi, Secretary. And thank you for this opportunity. And it's my privilege to have my teacher, Dr. Prabha Madam, who is chairing a session today. She's gem of a person, a very good academician. Thank you so much. Yes, we did continue the good work that is started by Nandita Palshetkar Madam, and we have done many workshops to prevent, and we said under the guidance and leadership of Shanta Kumari Madam, when I was a joint secretary, we have done many workshops saying preserve the uterus instead of saving the uterus, because it is saving was more, it was like defense. So we thought, Madam thought the preservation of the uterus, the preserving the uterus would have been a better terminology. And definitely, yes, there were rising incidences of hysterectomies in a young woman, especially in Telangana and all over India. Especially, there were misuse of these health schemes. We did have Aarogyasri, where there was some amount given as a health scheme, and the hysterectomy rates rose like anything. We couldn't control those. But finally, primum non seri, no, please do no harm, was the main agenda of the government. So it formed few rules that we had to follow those. And in 2023, Supreme Court has given some guidelines that are to be followed with the Union Ministry of India. So they said the monitoring, hysterectomy monitoring committees should be there at national level, state level, and as well as the district level, to actually curb the rising incidences, the high rates of hysterectomies. So definitely now we have many points to create awareness amongst the women, the community, and also the health workers and the health providers, obstetricians, to reduce the rate of hysterectomies and think of the alternatives of the hysterectomies. So the government has given us LNJ, IUS, and we have most of the OC pills and syndromic approach for the white discharges. And definitely we are following, and unless there is a proper indication, we are not going to do hysterectomies, and we are not doing also. And congratulations, Dr. Monica Singh. You have chosen a very, very good topic. This is the need of the hour. Definitely, we're going to definitely have a good take-home points. Thank you so much. And thank you for this opportunity, and all the best to you.
Thank you, Aruna ma'am. And
Thank you, Aruna ma'am.
Dr. Amay was so right that really when we weave together FOXY societies in one program, we get the viewpoints from different states and different zones, which is so integral to the basic fabric that FOXY stands for. And this is why all my friends are there. Dr. Radha has joined, and we are so grateful to all these three societies for collaborating with us today. So we will straight away go on to, I thank my co-convener who is there, Dr. Randhir Singh, and because of him, we could do the program together and without any hindrance. Myself and Randhir have convened this program along with two beautiful coordinators. We have Dr. Purva and Dr. Nandini. And now, Dr. Vishal, I would like to introduce the presidents and secretaries of Kanchipuram, Kurnool, and Vijayawada societies. Dr. Umayal Murugesan is President Kanchipuram OBGY Society. The name of Kanchipuram itself sounds so beautiful, like that the traditional sari. And Madam is always, very immaculately dressed, always very bright and beautiful at all times. And we congratulate Umayal Madam for having won the chairperson election of FOXY recently conducted. She is an alumnus of Chengalpattu Medical College, a gold medalist, and also Stanley Medical College. She is the managing director of Sri Kumaran Specialty Hospital at Tambaran, Chennai, and held several important positions in IMA as well. And of course, very active in FOXY. we welcome you today, Umayal ma'am. We would like to introduce the secretary to Dr. Umayal. Secretary Kanchipuram OBGYN Society is Dr. S. Vijayalakshmi, who is also very active in the South Zone. She's been active in the South Conference, member of IMA, and also WDW Society, which is very active in some states, member of Foxy Tapisar, recipient of Best Doctor Award from IMA Tambaran, and faculty in several Foxy conferences. Welcome, Dr. Vijayalakshmi. Kurnool OBGYN Society is headed by President Dr. Venkata Ramana sir. Sir is a very, very senior gynecologist who is practicing in Kurnool. He is an alumnus of Kurnool Medical College, a laparoscopic surgeon with more than 2 decades, 25 years of service in the government sector, and presently working as Professor OBG at Vishwa Bharati Medical College, Kurnool. Done a lot of surgeries ranging in something like 50,000. Active in the Alumni Association of KMC, IMA, as well as in Foxy, Adhira Awardee, Best Doctor Awardee, and Andhra Pradesh State Government DPL trainer. Welcome, sir. Next, I would like to welcome my dear friend, Dr. V. Radhalakshmi from Kurnool. She is the secretary of Kurnool OBGYN Society, presently working as Professor OBGYN Department at Santiram Medical College, Nandyal. And she has held various positions as a teacher, UG as well as PG from Kurnool Medical College, gold medalist and distinction holder throughout her undergraduate days, as well as university second position holder in post-graduation. Best Doctor Awardee, lot of UG, PG teaching experience, avid academician, and very active in Foxy. Welcome, Dr. Radha. I would like to welcome Dr. Tirupura Sundari Madam, who is Professor ASRAM Medical College, as well as ex-HOD of GMC Vijayawada. Madam has been very, very, active in the group as well. Every time I messaged her, sent her the flyer, sent her the intimation, she would respond immediately. Thank you so much, Madam. And next, I would like to welcome the Secretary of Vijayawada, Dr. Somalata Rapati, who is consultant OBGYN at Bhargava Nursing Home, Vijayawada. She is an alumnus of Guntur Medical College and also very active in IMS as well as endoscopy. She's affiliated to all major bodies of gynecologists in India, as well as held very important posts in Vijayawada OBGYN Society, of which she is the secretary right now. Recipient of Best Poster in Yuva Foxy 2018, speaker, panelist, faculty at various conferences. Welcome, Dr. Somalata. So, if one of you, Radha, or anybody would like to speak, or basically, you're most welcome. We would like you to tell us what you think about this topic and what are your viewpoints before we move ahead in the program, since you all
Dr.
are
Radha
together.
Lakshmi will speak, I think.
Yeah, Radha, why not?
Yeah. So good evening, all of you. Good evening, Amaya sir. Good evening, Monica, Tandir Singh sir, and Aruna Suman. Congratulations, Aruna, for your achievement as chairperson. And congratulations, Umayal also. So the topic of selection is very, very nice. And it is a topic necessary nowadays in the practice, because nowadays most of the hysterectomies are not done by gynecologists. These hysterectomies are done by surgeons. So they don't know the indication. For simple reasons, they are doing hysterectomy, especially in Andhra Pradesh and Telangana. So whenever a hysterectomy is done by a surgeon or other people like MBBS doctors, it must be scrutinized by the local DMHO, so that the unnecessary hysterectomies will not be done in the future. Thank you.
I think the similar problem is, being faced in all the states, Dr. Radha.
Sir, what is your opinion, sir? Amaya, sir?
Dr. Monica, madam has joined. DME madam has joined, I think.
Oh, good evening, Aruna Kumar ma'am. I can I see madam? Madam, I'm not able to see in my screen. Good evening, Dr. Aruna Kumar. Has madam joined? I don't
I'm
think
able to see some government KGH.
No, madam.
From Vijayawada.
Tripura Sundari, madam, is from Vijayawada.
Yeah. No, ma'am, that's another designation.
Okay, sorry.
We will wait for her. And Radha, thank you so much. The similar type of situation is being, faced in all the states. And that's what we are, trying today, that one speaker is speaking about regulations. The other speaking is talking about robotic hysterectomy. So we want to see whether new technology, can go hand in hand with regulations. And as we welcome the new technologies and new techniques and the laparotomy, the style of laparotomy is going out of fashion, out of vogue, and we are coming to minimal invasive and high-tech techniques. Is it necessary to also curb our indications, like make them more stringent, make them more guideline driven, so that every hysterectomy which is done, especially in a younger woman, is scrutinized by a checklist, by some government authorities or a government private combined association, wherein the rates could be brought down and alternative therapies, like Aruna madam said, could be worked out for these women. Because I basically, being from the fertility field, I know the importance of the uterus and ovaries tremendously. But even if the woman has completed a family, she doesn't have, nobody has the right to remove her uterus and ovary, or both, or either of them, without any definite indication.
Yes.
So having said that, let us move on to our program. And we'll hand over the first session to our coordinator for today, Dr. Purva Bhatkur. She's a very, very active girl in our team. She's assistant professor, Gandhi Medical College, Bhopal.
No,
And
Monica,
Nandini?
just 1 minute.
Yes,
Tripura Sundari, madam from Vijayawada. Please
Madam,
ask the
yeah,
madam joined already.
yeah, we can wait for madam to join, and then madam.
No, already joined. You ask her to
Yeah.
few
Tirupura
words
ma'am,
regarding Tripura Sundari, madam, is there.
Tirupura Sundari ma'am, if you are there, please unmute, and we would like to have your blessings, madam.
Yeah, she was there. That is ISO and government KGH.
Yeah, I also saw her. She was there, but maybe she's, right now she's busy
Okay.
with her. So Purva, you can start session 1.
Yes, ma'am. So moving to our academic session 1, that is on rules and regulations for hysterectomy. I invite chairperson Dr. Jayati Reddy madam. Madam is presently the president of Hyderabad OBGY Society. She will be joining us shortly. Next we have Dr. S. Venkata Raman sir. So, sir is presently president of Kurnool OBGY Society. He is having a vast experience of more than 25 years and is presently working as a professor in OBGY department, Vishwa Bharati Medical College, Kurnool, and is very instrumental in surgeries. Next, we have Dr. Umayal.
Excuse me, Sergeant Venkatramana sir.
Yes, madam. Thank you, madam. Thank you for a nice introduction. Thank you.
Thank you. Next, we have Dr. Umayal Murugasan, madam. Madam is presently president of Kanjipuram Society, and she is managing director of Sri Kumaran, a specialty hospital at Chennai, and she is executive member and a very active member of Kanchipuram Society. We welcome you, ma'am. Now I hand over the session to our chairperson to introduce our speaker, Dr. Archana Mishra, madam.
Any problem, Purva? Purva, you're muted.
Hello.
Yeah. Yeah. Any problem?
No, ma'am. Sir will introduce madam.
Okay. Okay. Yes. Yes.
Yes.
Venkata sir, good evening. Good
Yes,
evening.
madam. Good evening, madam. So now the topic is regulation guidelines of hysterectomy. Speaker is Dr. Archana Maestra, madam. She is a senior giant director, maternal health, Ministry of Government of Madhya Pradesh, and is a member of the national level committee at various Laksha, IPOS, SBI, GDM, and various committees. She is nominated for best practice in national summit, represented by Madhya Pradesh International Conference of the GDM Women's Right. So I welcome you, madam, for this conference webinar, madam. Thank you.
Thank you, sir. First of all, I would like to thank our convener, Dr. Monica Singh, and co-convener, Dr. Ranjit Singh, for organizing webinar on such an important topic. It's a neglected topic, I believe, because in the government sector, we just talk about obstetrics and no gynae. So it was very much required, and she has given a very challenging topic to me. I'm going to share some data and guidelines. My teacher and our chief guest of today, Dr. Aruna Kumar, DME, will be joining shortly. Our guest of honor, Dr. Amay Purandre, I thank him also. Special guest, Dr. B. Aruna Kumar, and the president of Kanchipuram OBGY Society, Kurunul OBGY Society, and Vijayawada OBGY Society, and young lot, Dr. Purva and Nandini Singh, who are the program coordinators of the Synergy Club. So again, I thank you, Monica. I'm starting with my presentation. So I'll be sharing the screen.
Yes, madam.
Can you see the screen?
Yeah, we can see, madam, you can make it full slideshow.
It's full size, Monica.
No, right now we are having the normal view.
Okay. Just we'll do it once again.
Yes, ma'am.
Okay. Hope it's full screen now.
Ma'am, slideshow में current slide से.
अच्छा.
Yes, ma'am.
It's gone. Gone. The share has gone. From current. Oh, beginning, yeah. You have to go to the current slide, left hand corner.
Now it's okay.
No. You have to go to the top bar. You can see from beginning and from current slide. Please click on current slide. Yeah, please click on this. No, you have not clicked on this.
No. Oops.
Please click on the current slide. Yeah.
Now it's okay. Or should I share my presentation to you?
No, ma'am, it's okay. I think it should work out. The thing is that we are able to see the normal view. We are not able to see the full screen, but we can make it out. There's a problem. We'll go like this.
I think Archana ma'am, you start the slide sharing. The PPT, no, madam.
Beginning.
You start the slide share.
Now you can see.
Yeah, we can see the slide, madam, but we cannot see the full screen.
Full screen. You cannot see the full screen. Now?
No. It is still the normal view.
Ma'am, if there is problem, you can share it with me. I'll move the slides then.
Okay. Okay.
Yes.
Madam, do double click on that button just now. What you do now, do double click, it will become full screen.
She is not able to do it actually.
Acha.
Open the full slide view only before sharing, if you want.
व्हाट्सएप कर रहे
Purva, I think you will receive the slides now.
Yes, ma'am.
Monica, I have shared with you.
Okay. Madam, personally, with me or in the... Yeah. Purva, I'm forwarding in the group, okay?
I've shared with Purva also.
I've also received it. I'm just sharing it.
Yeah, please do. It happens, madam, with VIPs, it is their VIP syndromes.
It can be police also. So, a person who sits in the chair, it's full of challenges. Never very smooth.
This is like the topic you're speaking on.
So, let us, I can share the, in my presentation, I'm sharing the trends of hysterectomy through NFHS data. And this is a National Family Health Survey and it captures the hysterectomy data also. So what is the national average of hysterectomy and where Madhya Pradesh stands? After that, I have taken the data which we collect from our district hospitals, government hospitals regarding hysterectomy, the age, though we do not get very detailed details of each hysterectomy because Government of India says that we should have a line list of it. So
Yes,
let us start with this
the
thing.
slides are ready, ma'am. Yeah.
Slides are visible?
Yes,
Yes, it's
they are
visible.
perfect. Yeah.
Yes.
Thank you, Purva. Can I have next slide?
Yes, ma'am.
Can I have next slide? Like this is the national pattern of hysterectomy. We can see in the southern state, the prevalence of hysterectomy is high. In Madhya Pradesh, if we look at, we have taken the reference from two surveys. One is NFHS 5. It was for 2019 to 21, and other is LASI, that is 2017 to 18. Both of them shows that if we look at hysterectomies from 40 to 49 years and above 50%, 8.5% women undergo hysterectomy. Next, please. Now, between 40 to 49, what does NFHS say? The national average is 9.7% women undergo hysterectomy. In Madhya Pradesh is 8.5%. And when we look at Andhra Pradesh, Telangana, some northern states also like Bihar, Gujarat, and Ladakh is also showing more than 10%, to 11.5% women undergoing hysterectomy between age 40 to 49 years. Next, please. So if we look at age-specific prevalence of hysterectomy, between 15 to 29 years, it's just 0.2%. We have compared two surveys. One is NFHS 4. It happened in 2015-16 and NFHS 5. It happened in 2019 to 21. The N is also given. 62,000 women were interviewed, and in NFHS side, 48,000 women were interviewed. Between 30 to 39, only 3.2%. And the median age of hysterectomy is 36 years, and 8.5% of the women undergo hysterectomy. So it's quite a large figure if we see in women of reproductive age group. Next, please. So this is the map which is reflecting the prevalence of hysterectomy across the state between 40 to 49 years. We can see the Malwa region and the one district, Chhatarpur, it is adjoining to Uttar Pradesh. Here the prevalence of hysterectomy is high. And if you look at district-wise, Devas, it is 21%. It's near to Indore, which is a metro town. Ujjain is also a metro town. It's near to Indore, where medical college and private sector is dominant. Then Sihor and Chhatarpur. I don't know why Sihor, maybe because it is near to Bhopal. When the women were interviewed, they might have undergone hysterectomy in Bhopal, and the Chhatarpur, it's near to Uttar Pradesh. So the legend shows low prevalence, that the light cream color 1.7 to 5.4, mid prevalence between 5.5 to 8.8, and high prevalence from 8.9 to 21.3%. So the Malwa region near to Indore metro cities and near to bordering Gujarat and Maharashtra, the level of the prevalence of hysterectomy is high. Next, please. Now the self-reported reasons for hysterectomy. The women were interviewed, though the group was not too large, but the women between 40 to 49 years who underwent hysterectomy, they cited the reasons that it was because of excessive menstrual bleeding. And we know that excessive menstrual bleeding, there are hysterectomy is not recommended in each and every case. There are medications available for it. And but the women who have cited the reason is excessive menstrual bleeding. It is followed by fibroid and others non-classified reasons. The reason cited was on layman's language, which is uterine prolapse and uterine disorders and cancer. But Palm-Cohen classification was not followed in NFHS. Next, please. Next, please. Next. Now the factors associated with hysterectomy in Madhya Pradesh. This is all the salient features of NFHS. The older age, there was greater odds of hysterectomy. The level of education was also a contributory factor. The less educated women had undergone hysterectomy more. Rural residents, the rural women, 1.5 greater odds were there for hysterectomy. We were thinking that urban women are undergoing hysterectomy more, but it was the rural women who were undergoing hysterectomy more. Or from the this wealthier household, for in the women with lower this thing income group, it was more in low income group. And in the multiparity, the hysterectomy prevalence was high. And those who have not been sterilized had undergone hysterectomy more. So these were the key factors which were highlighted in NFHS. And the two potential contributory factors are also, I have mentioned what NFHS has written. I have quoted those, this thing, limited awareness of the women was leading to hysterectomy more. And also they have written that financial incentive is motivating our doctors, though I do not agree with it. Being a gynecologist myself, that's fine. Because of financial incentive, the doctors are going for hysterectomies in unindicated cases. But they have quoted like this. Next. Next, please. Now, the place of hysterectomy. This clearly depicts that a private facility, 61% of the women are undergoing hysterectomies in private hospitals. There are variations across the state, but in the private facilities, definitely
Madam, your network is,
hysterectomy reported were more from my side.
yeah, slight network issue, maybe. If you are in network, it's okay. Maybe a little time, for a few seconds, the network went, but now it's okay.
So, Purva, you can change the slide now. Huh. So we have already discussed this, that in urban as well as in the rural facilities, the private sector are contributing more in hysterectomy surgeries. So this is about the wealth quintile of the household. It clearly shows that again the trend is same. Now hysterectomies and NCDs. The women undergoing hysterectomy, as cited by Lassie study, longitudinal aging study in India, and so was conducted by IIPH Mumbai in collaboration with Harvard School. It shows that there are 1.5 times higher odds of hypertension, 1.7 times higher odds of diabetes, and bone disease, but they have not correlated it with oophorectomy. How many women underwent hysterectomy with oophorectomy or ovariotomy? So they have just written that in the study that the women are more prone for NCD after undergoing hysterectomy. So it's the study is adjusted for age, education, marital status. The details are available and we can go through the study also. Next, please. So definitely, if you look at number of hysterectomy in any hospital, there is a need of audit. And Ministry of Health has released guidelines in 23-24 for audit of all the hysterectomy, whether it is vaginal hysterectomy, lap hysterectomy, or abdominal hysterectomy. The government is supposed to do audit of all the hysterectomies, getting line lists from the private sector as well as from the government sector. Next, Purva. So why this all this data we have seen so far? Hysterectomy, it is perceived as a definitive solution for various gynecological conditions, but being gynecologists, all of us know that it's a last resort, and there are specific indications, there are specific treatment protocols available with FOXI, with government. Everywhere we have protocols and we need to follow this. Sometimes the community is also responsible, and they are pressing hard on the doctors to undergo hysterectomy. So the guideline states that it is the policy makers, the service providers, and community. All the three are responsible for this high prevalence of unindicated hysterectomy. Some conditions they have cited that where hysterectomies may not be necessary, that is AUB, fibroid. If the family is completed, the women say that my family is complete and I'm having bleeding PV or white discharge, I want to get rid of my uterus. So the completion of family is also one of the reasons, and the fear of cancer in cases where there is cervical erosions or precancerous lesion is suspected, but without undergoing colposcopy or cervical biopsy, even the women and her family members stresses upon that we need hysterectomy. We will not like to go for follow-up. So even in the cases where non-surgical options are there, the patient they themselves press upon, and they force the doctors to take this decision. Next, please. So what is the imperative for audit? We have both private and the government sectors are working hand in hand for the common cause like reduction of maternal mortality. And from 17 September onwards, we will have an Abhiyan Swasth Nari Sashakt Parivar. So if we look at our Honorable Prime Minister's vision of keeping each and every woman healthy, so that her family feels empowered, and the family is empowered. We need, all of us have to work together, and some self audits are required. Though ministry asks government to do the audits, but it becomes very difficult for getting the data from the private sector and getting audited from state. So it is oneself who has to look at the records, look at the data, analyze the data, and do the self audit themselves. So overutilization, definitely the data shows that overutilization is there. And now Ayushman Bharat scheme is there, where the women or the family is entitled for rupees 5 lakh treatment. And in Madhya Pradesh also, we have private medical colleges, private hospitals who are accredited for doing hysterectomy, laparoscopic also, and conventional also. There is variation in practices also. The audits are there, defined very meticulously, and one needs to follow. Evidence-based medicines are there. Patient safety outcome will be improved if we go for audits, and systematic review of hysterectomy procedures will be there if audit is done. So it's the national and the state need that one needs to go for audit. And here I thank again Monica and all the societies we had linked together and have kept discussion on this very important topic, that we will have talks on modern methods of hysterectomy, but audit is important. And all the state chapters and the particular district chapters, they should also talk about at least once in a quarter about this important subject of unindicated hysterectomy, and also like sending of the data, submission of data, so that it can be actually analyzed at state level. Next, please. Next. So what does the programmatic guidance shows? If you look at ministry's guidelines, I will share the guidelines in the group also. The interventions are available at primary, secondary, and tertiary level. If we look at primary level, the counseling of the patient is very important, and the referral of the women. Capacity strengthening of medical officers, staff nurse, CH, community health officers, LHV, and ANM. They need to be well oriented on gynecological needs of the women, because currently all the trainings are focused on the obstetric need of the women, and the protocols or the counseling material, learning resource packages for gynec services are not available. So government in collaboration with Foxy can have this IC material for the service providers who are working at grassroots level, so that the women are well oriented on it. And then to refer the women from HWC, which is also called now ARM. ARM means Ayushman Arogya Mandir, that is at sub-center level. Awareness generation is important, and health insurance, when it covers hysterectomy operation, but it has to be used judiciously. I have asked our Ayushman Bharat office to give me the numbers of hysterectomy which have been reported in Ayushman hospital. They are analyzing. It again reflects that nobody is looking at the data, how many hysterectomies are happening in Ayushman hospitals also. So these programmatic guidance are important. It is very important for all the states who are doing it, though it's the responsibility of government, but it cannot be done solely by government itself. The Foxy is required to join hands with the government along with the nursing home associations and IMA. Next, please. At the
Ma'am, is my screen visible?
Yes, it's visible.
Yes.
But it's not moving. Next is monitoring.
Now it's
So next, monitoring and evaluation. The ministry has given a three-tier system. At national level, there is a national monitoring committee for hysterectomy orders. Then at the state level, a committee is there, and then at district level, we have district quality assurance committee, who's supposed to do hysterectomy audit in every quarter. Next, please. Next. So at the state level, we have a principal secretary who is an IS officer, who is the chairman of the state hysterectomy committee. We have not formed a separate committee. We have a state quality assurance committee. We have added the responsibility in their TOR that they have to do the audit of all the hysterectomies also. We have included our NCD officer who takes care of cancer and hypertension and diabetes. There is a FOXY member also who is the included in this state hysterectomy committee, and the development partners like UNICEF, ANTRA, and UNFPA who are there in this committee. And this committee has to meet once in every 6 months. We had a meeting in November 2024. It's now nearly 1 year, and our principal secretary asked me and the other committee members to just create awareness. We cannot audit from state level, so all the doctors and associations have to be taught on self-audit, and the committee needs to be aware when to report to doctor, when to go to the doctor, and just going to a private doctor for gynecological this thing. And if they suggest hysterectomy, he suggested that the judicious decision has to be on the part of private sector. So it cannot be done from state level, from the government side, because again I said there is a Clinical Establishment Act, and in that act private sector has to report the number of hysterectomies along with the line list to government. But getting the data, because there is no portal or no software, no technology is used for submission of data. We have HMIS portal, which is its login or ID and password is shared with all the private sector, and they submit the number of hysterectomies done by them monthly. But we do not have line listing of the women undergoing hysterectomy, because it's a matter of privacy also, I believe. So at least if we get the number of hysterectomies done by medical colleges and private sector, we can do a audit at least the young women undergoing hysterectomy. So that age part, it can be covered. But who were the women whose ovaries were removed, histopathological report was there or not, whether it was done by general surgeon or gynecologist, these details are not available in HMIS, but at least submission of data in HMIS will help us a lot. Next, please. Next. So at district level also, there is a district quality assurance committee which is headed by district CMHO. NCD officer is there. So in Madhya Pradesh, we have formed a committee, and I would like to share with all of you that at ministry level, when we have this parliament session, then we get questions on how many women have undergone unindicated hysterectomy. So the government is very serious and very concerned about this hysterectomies in younger women. So we have to maintain this data also. So again, my request is there for the submission of data in HMIS portal. And one thing is more, we got some complaint in one of the district of Madhya Pradesh, where general surgeon had done 350 hysterectomy in a span of 6 months. And when we analyzed the record, we came to know that there was no pre-examination by a gynecologist, no proper indication, no USG was done, no curettage was done, and hysterectomy was done straight away. And the case was reported to NMC, and his license was also suspended. So we have taken some hard actions also in our state. In one of our district in the northern part of MP, that's called Guna, the rate of hysterectomy is very high. So a committee has been formed to look at this. So we have to be very careful, and from the government side, we have the numbers, and we have started taking the action and auditing the part. And now we have started including the FOXY members to get the technical this thing also inputs from them. Next, please. Next, please. I think this is the last slide. Next, please. Next. So slide is not moving.
Purva?
Hmm.
Yeah.
Okay. So the clinical protocols are there. I will share the guideline. This is the format which is available. Now, some data I would like to share from our districts also. We got the number of hysterectomies, like 3,000 hysterectomies in 1 year and 1,600 and just we have passed half a year. But if you look at the numbers, in less than 40 years, 27% of the hysterectomies were done. And the indication of hysterectomies were about 35% was because of menorrhagia. And again, the specialist who performed hysterectomy was general surgeon in 62% of the cases, and in only 38% gynecologists were doing the surgery. This is all the data from government hospital. It's not from private hospital because we are not receiving the data from private hospital regularly. This is all from government hospital, and it clearly shows that even in government hospitals, the general surgeons who are taking lead in doing the hysterectomy, but they can do, but again, in indicated cases, if the women, the ailment can be managed with medication, first the gynecologist should start with the medical management, and then the case should be referred to general surgeon, or she can do hysterectomy with general surgeon. Next please. Next. So there are few challenges which I would like to enlighten to my elite doctors. There are some expectations that unnecessary hysterectomy for the public sector providers also needs to be avoided. Monthly reporting is required in the prescribed format, and awareness at field level to Anganwadi worker, ASHA and ANM regarding the like perimenopausal conditions. If she has having menorrhagia for just 2-3 months, she is not a case for hysterectomy. So evaluation of the patient is important before referring her for any management and taking decision for hysterectomy. And for the private practitioners also, hysterectomy is the last resort of treatment. Again, monthly report. I urge my private sector providers who have joined this important webinar. Reporting is very important from all the nursing homes, medical colleges, both government and private, and the RCMHO, Chief Medical and Health Officer. They will be able to do the audit when they get the data. So data submission is important for analyzing the cause of hysterectomy, whether it was performed for a proper indication. Next, please. So in new future, Save the Girl Child will turn to Save the Uterus. This is all is my message. Again, I thank Monica and all the three organizers and the chief guest of honor, and the special guest for conducting this webinar on very important topic. And again, self-audit is very important, and submission of data to the government for proper auditing by expert. That will actually help us in sharing the observations with FOXI and the private sector providers so that we can self-ponder and act upon. Thank you so much.
Thank you, Archana ma'am. It was a very, very insightful lecture. And this is a subject very close to your heart, I know. So, chairpersons would like to comment. Venkata sir, Prabha ma'am has joined, madam. And ma'am, would you like to comment on the after
Yes,
the lecture?
madam. Yes, madam. It is a very pertinent topic of today, actually, hysterectomy. So when you want do the hysterectomies and when you don't want to do the hysterectomies, so a person like the speaker from the position of giant director, so she narrated nicely. So it is useful to all the people, madam. Thank you, madam. Thank you.
So, Archana Didi, the main thing which struck me was that figure of 350 hysterectomies in 6 months.
Yes.
That is 50 hysterectomies in 180 days.
Yes.
That is 2 hysterectomies per day.
Yes.
And
done by general surgeon.
General surgeon. So I think like we are doing our PCP&DT form filling so religiously, so meticulously. If there is a form like this which is filled for hysterectomy also, and a copy is sent to the district hospital, where indications are like in PCPNDT form, we have got these 26 indications, the same type of indications in the hysterectomy form. And then countersigned by somebody from the government sector or the private sector, 3 or 4 gynecologists should say yes. After that, only the patient should be taken for hysterectomy. If you
Monica,
start
difficult.
मेरा तो ये, I mean, means just I thought, you know, how to prevent this rampant encroachment on women's right.
नहीं,
And
और
we can
I think
teach and educate our gynecologists, but how to tackle the general surgeon?
Actually, Didi, I also have a one input, Shabana here.
Yes, Shabana.
Yeah. The rules should be followed very strictly. Another thing is, on one side, the government is promoting program of cancer screening. That's really very important. And on the other side, these nursing homes, they are taking advantage of this particular fear of cancer, uterine cancer, cervical cancer in that particular lady. Like white discharge है, तब भी patient के दिल में डर है कि hysterectomy करवानी जरूरी है because cancer फैल जाएगा. Without consulting any gynecologist, these nursing homes, they are just calling surgeons, general surgeons, without doing a PV examination. These patients, they are posted for the OT for hysterectomies.
Yes, I agree. I agree with this, Dr. Shabana, because you are sitting at the head of the biggest tertiary
So
institute.
we are also dealing so many patients. They are coming in our gynec OPD post-op patients. They are coming with various complications. Young ladies, they are coming with the stitches. Young lady, they are coming with the wall discharges. Bus hysterectomy kar di, and they are not, I mean, understanding the consequences after that.
Yeah, because some of the biggest government, all of you who are handling the government
So
machinery are
this
sitting.
rule, I totally agree with Monica Didi, Archana Didi. Ye rule we have to follow this audit rule very strictly from the private sector, because I think nobody is reporting nowadays. Medical colleges, government, they are sending data through central HMIS, but otherwise the data is totally incomplete from the private side.
We have asked our CMHOs, and actually CMHO is responsible under Clinical Establishment Act to get the data from private hospitals. So, and long back means not too, but last year I have shared letter to President MPOX also, like Madhya Pradesh Obscini Society President, and it
He
was shared to
circulated
all the
also,
folks.
Kavita Singham circulated that, I mean, the letter for reporting hysterectomies.
So getting the data from everyone becomes a Herculean task, because we are tied up with other for this thing also, and responsibilities also. So getting the data, because there is no such portal, there is a format and one has to submit. We are not
Yeah.
asking for numbers, we ask for the line list. I think Foxy can come forward, because in the district level committee and at the state level committee, the Foxy members are there. So if a Foxy members tell
Archana
his
Didi,
or own color.
I feel is Foxy is there to oversee all the affairs. Government is sitting at one center of the state. The peripheral private practitioners are there. We have brought down sex determination to drastically low level in every state of the country through stringent paperwork and scrutiny. That is the only way. Madam, I don't think, I might be a very small speck in the private practitioner scenario, but if we give the responsibility to private practitioners to do it on their own and to Foxy to oversee, we will not get the results. The only results will be obtained when there is a proper documentation, mandatory documentation like PCPNDT. This is my, but I hope we can do something in the near future, madam.
So, Monica, you are right. So, I think by next week, all the private sector will get a strict letter from government to submit the data of last 6 months, because we have got data only from 3 nursing homes across the state, and from none of the medical college we got the line list, even from government as well as from the private Medical College. So that's a good suggestion, and my colleagues and from medical college and from private sector are suggesting this. So I feel we should be strict as a government side. So we will definitely share directives as well as a format where the signed copy of this thing would be required.
Definitely.
Okay.
Hey, madam.
Thank
because-
you.
madam.
Thank you.
Good evening. I am Dr. Prabha Devi from Vijayawada, OBGYS.
Good
So,
evening.
as Archana Mishra has told, the more and more of hysterectomies were being done in government hospital. It is not by gynecologists but by surgeons. But once there is facility of having OBG department, surgeons are not supposed to do hysterectomy, definitely. So unless otherwise the help is needed.
Data from the private, not in the
No, even
government.
she represented, Archana Mishra has given the statistics that is from the government hospital. It seems the
I think
surgeon
the
has done.
government hospital surgeons, they are not doing.
No, that is that census it has given by Archana Mishra.
Shabana, data was not from medical college because medical college का तो हमारे पास data आया ही नहीं.
Not in medical
This
college.
is from
District hospital.
district hospital,
Okay.
and in nearly
Hospital.
58% general surgeons are doing. The main surgeon is general surgeon. It is assisted by a gynecologist.
Gynecologist.
Okay. Huh.
So
And
it is not in the department of OBG, or is it in the department of surgical? The case is being taken.
it is the
The
case
case where
sometimes goes.
it gets registered.
District hospitals, madam. District
No,
hospitals.
government
From the
hospital.
district
Under-
hospital,
Under
not of the
OBG,
medical
under
college.
OBG specialist or under surgical specialist.
Actually, what happens, ma'am, if you look at Madhya Pradesh, there are 52 districts. And in nearly 30% of the district hospital, we have two gynecologists. Okay, they are tied up with obstetric first. So when the women comes, they are seen by a gynecologist, and there are general surgeons also who are doing surgery, and they are doing private practice also. In our state, private practice is also allowed. So
Yes.
sometimes they go directly to these general surgeons, and they ask the gynecologist, you just come and assist, and I'll be taking this case for hysterectomy. This is happening. And in the private sector, like since the data, we got data for last year from few hospitals, but this year again we have not received any data, so I was not able to analyze it properly. From the government sector, we are getting the data.
Okay. Even we being obstetricians and gynecologists being blamed for both cesarean high incidence as well hysterectomy high incidence. That is the pitiest thing. Now it is going on.
But ma'am, Prabha ma'am, thank you for being there,
Okay,
madam.
nice.
You are teacher of teachers, madam.
Okay,
And
thank you.
Prabha madam, I just wanted to say that gynecologist of today is a very conscientious female, and she and he, they understand the implications of increased cesarean section rates
Definitely.
as well as the increased hysterectomy rates, because the implication will be on so many reproductive health issues as well as fertility.
Even
That-
ovaries are getting removed even at the early age along with hysterectomy by surgeons. That is
Yes,
the
ma'am.
still more piteous thing.
So, ma'am, the regulations have to be stringent. There is no other way we can control.
Yes.
It is not, madam, a soft approach will not work here. That is my, that is my opinion. Thank you
Nice.
so much, Archana ma'am, for giving us that data. And
Very nice data collected.
yes, madam. Yes, ma'am. We are so thankful that Archana ma'am, you could, take out time and give us that insightful view on hysterectomies, which can be avoided. So thank you so much. And I think, Dr. we can move on to session 2.
A very good evening to one and all. Moving ahead with the second session, which is on advancements in hysterectomy by a very well-known speaker, Dr. Priya Bhave. To chair the session, I would like to invite our esteemed chairperson. Our first chairperson is Dr. Sridevi Velanathan Madam. Our second chairperson is Dr. Kore Prabha Madam. And our third chairperson is Dr. Mahalakshmi Madam. Dr. Sridevi Velanathan Madam. Madam is currently the consultant at Sri Vijaya Maternity Hospital at Vijayawada. She has been awarded various prestigious awards such as Shri Kovi Radhakrishna Murthy Memorial Prize, and she has also won the second prize for paper presentation. She has been the past president at Vijayawada Oxkani Society. She is also the recipient of All India IMA President Award, and she was the founder secretary of Andhra Pradesh Oxkani Society. We welcome you, madam.
Thank you for the nice
And-
introduction.
Thank you, madam. Thank you. Our next chairperson is Dr. Kori Prabha Devi, madam. Madam has been the former professor and head of department at NRI Medical College General Hospital, and she has worked in all her capacities in Siddhartha Medical College. She has retired as a head of department at SMC Vijayawada, and she has been the former president of Vijayawada Oxkani Society. She has been awarded the Be Bold Doctor Award by the Honorable Rajashekhan Reddy, sir, the Chief Minister of Andhra Pradesh, for HIV/AIDS in 2007. It's an honor to have you, ma'am. Welcome. Our third chairperson is Dr. N.K. Mahalakshmi, madam. Madam is presently the director and professor of gynae in Institute of Social Obstetrics at Government Kasturba Gandhi Hospital for Women and Children at the esteemed Madras Medical College. She has a vast teaching experience of more than 2 decades. She is specially trained in obstetric hysterectomy and colposcopy with a special interest in infertility, lap surgeries, high-risk obstetrics. We welcome you, madam. Now I request our chairperson to kindly introduce our speaker for today.
Thank you. It is my privilege to introduce Dr. Priya Bhave. At the outset, I would like to congratulate and also thank Dr. Monica Singh and her team for organizing such a wonderful, insightful webinar on the most common surgery being performed by gynecologists, that is hysterectomy. Dr. Priya Bhave, she's a very illustrious person. She's the director, Harmony Institute of Excellence in Reproductive Health, teacher of FNB in Reproductive Medicine, ex-faculty DM Reproductive Medicine, Foxy recognized trainer in basic and advanced infertility management courses. She's a Cochrane reviewer and author, secretary MP chapter of Indian Fertility Society, awarded Dr. Pankaj Talwar Gold Medal at IFS 2022. She is an Ironman triathlete. That is what does it mean? Okay, she's a managing committee member IAGE 2023 to 26 and first in world to do gynec surgery with Apple Vision Pro device and first in world to do telerobotic surgery from the Mantra M bus and first gynec to do a surgery telerobotically from Delhi to Bhopal. Congratulations, ma'am. We are all very eager to hear from you about the advancements in hysterectomy.
Thank you, ma'am. Thank you so much for this kind introduction. I would like to I would like to thank Dr. Monica Singh for organizing this webinar and for having me here. It was really a wonderful session by Dr. Archana Mishra because as gynecologists, all of us know that are you able to see my screen?
No, not yet, Priya.
Okay. Start. Are you all able to see my screen now?
Yeah, we can see
Okay.
the screen.
Thank you so much.
Yeah.
So thank you so much, Dr. Monica and your entire team for organizing these wonderful Synergy webinar series, which have been really going full throttle and making waves across the country since almost the last 1 year. I would like to also thank everybody for their interest in this topic and giving me a very liberal time to talk about robotic surgery and specifically robotic hysterectomy. And also, I would like to briefly touch upon the advances in hysterectomy through this presentation. So we all know that it's the commonest surgery worldwide. And in our country, the most important or the commonest indications of hysterectomy, 1/3 of them are for fibroids. In certain countries like Africa, almost 80% of the hysterectomies are because of fibroids, because fibroids are way more commoner there. We have a significant incidence of multiparity, so almost 15% are for prolapse. For malignancy, 10%, obstetric hysterectomy is 5%. And of course, there is a lot of underreporting and non-reporting. So this data could be incomplete, but as Dr. Archana said, we will have a better reporting of hysterectomies. So eventually in the times to come, we will know it better. So when we talk about hysterectomy, what is new in hysterectomy? Of course, the first thing that comes to our mind is the use of the surgical robot. Also, what is quietly coming up is the reduced port hysterectomies. All of us use 3 or 4 ports, but now single port surgeries, which had a boom almost 10 years ago, are slowly coming back. And also V nodes. Vagina is a orifice wherein if we perform the hysterectomy vaginally and use laparoscopy with that, it gives you the advantage of both. It gives you the advantage of the vaginal route as well as it gives you the magnification and it gives you all the advantages of the laparoscopic route. So single port and V nodes hybrid approaches plus robotic single port. That is something which is going to be the game changer, I feel, because the small space in the vagina, when we put in the robotic arms are able to articulate. And so that is something which I really look forward to. And that is probably something which we all should watch out for in the future. Something which we all commonly now do is use the barbed suture and the other novel absorbable sutures for vaginal cup. It is not something which is very, it is something which has become quite common. Along with the surgical technique, what has happened simultaneously in the field of recovery is the ERAS protocol, that is the Enhanced Recovery After Surgery protocol. And eventually, we all may be looking at same-day discharge pathways with robotic hysterectomy. All of us remember that cartoon from Akola, Dr. Rajesh Modi, lady walking out of hysterectomy, calling it, or Dr. Kavita Bapat, who popularized one-day vaginal hysterectomy. With robotic surgery, because there is no port side pain, so this has almost become a reality now when we use these platforms. And of course, the use of the robot gives us a very big advantage. We are now able to integrate imaging, artificial intelligence, and combine it with our surgery to refine it. This is because the robot is actually able to time all your movements. The robot is also able to analyze all your movements. So eventually, when the robot has enough data, it may actually be telling you how to improve yourself. So as you progress in your surgical journey, the robotic surgery may actually help you in telling you what are the superfluous movements that you did, what are the times where your instruments were out of vision, and so you are able to improve yourself. And the biggest advantage is that now, because of the expiry of the patent of the intuitive surgical system, the access and the cost landscape is slowly evolving. So now we have many more players, and at present we have 5 players in India who have the license. And in the times to come, we will have a flood of systems which are going to come, all of them with their own advantages and disadvantages. So here today we will be talking on the platforms which are there for the surgical robot, the approaches, that is the robotic single port, robotic V nodes approach, and we are going to talk a little about suture technique, ERAS, same-day discharge, and we are mainly going to talk about my experience in robotic hysterectomy, specifically telerobotic hysterectomy. So the Da Vinci SI system was the one which was in India for the longest time. All the robotic surgeons have been using this. It was because of the prohibitive cost limited to large corporate hospitals where the patient paying power is more. Very few public sector hospitals like AIIMS had a Da Vinci system. The second generation was the Da Vinci XI system. XI system also has a lot of installations in the country. The advantage is that it has something called as a Firefly mode. So Firefly mode is like an augmented reality. At all times, you are able to visualize the ureter as a fluorescent green structure if you inject the dye into the ureters pre-op. So the advantage of the Firefly mode is not only to visualize the ureters in gynae, but also to do the sentinel lymph node biopsy with the ICG dye, to check your anastomotic site vascularity. So this is the one advantage of the Da Vinci Xi. Now, Da Vinci has come up with the latest model called DV5, which is not yet launched in India. The price is going to be more than 30 CR, but everybody is looking forward to what features it will have. The system that I use is the SSI Mantra 3 system. So the SSI Mantra 3 system has got a little difference from the intuitive system. If you look at the intuitive system, all the arms are together. And in the Mantra system, the arms are modular. The advantage of modular arms is that not everybody will buy 4 arms. Some of us will buy only 3 arm system. So 1 arm for the camera and 2 arms for the instruments. So these are modular, and every arm can be in different location in the operating room depending on the surgery and the port placement. The patient cart has a recorder. It also has a continuous UPS supply, and it has a insufflator and a cautery on it. In the left hand corner, you see the surgeon sitting on a console. Now just contrast this with intuitive, wherein it is a immersive console. So the surgeon has to look inside and they feel as if they're standing inside the patient. But the one disadvantage is if you want to communicate with your team, or if you want to look at your team, your eyes will get off and your instrument will freeze. We all know that in all robotic cases, we always put one laparoscopic arm. That is for suction, that is for introduction of the sutures. And so a good communication with the OT team is very important. And so many surgeons are actually more comfortable with the open console design, which the SSI Mantra has. The third system, which actually was the second in India, is by Cambridge Medical Systems, that is the CMR system, and it is called as Vercius. If you look at these arms of the Vercius, you can see that they are they're small and they are modular. So again, Vercius comes with 3 arms, but these are very small and they are really good handy arms. They can get accommodated even in very small theaters. And CMR also has a open console. So the surgeon does not have to go inside. It's an open console, and the surgeon is free to talk with the OT team. Now, these are the 4 arms. What we have brought is the 3-arm system. There is also an option of 5 arms. So certain oncological extensive surgeries, they require 5 arms. Now, so you can have 3 arms, 4 arms, or 5 arms. Now, what happens is whenever you put the ports and you fix the instruments, you then dock it. Docking is just like docking of the ships at the yard. So after docking, the arms will not move. This is very, very important for safety, because once your instrument is inside, if the cart moves, if somebody pushes the cart, then there can be a problem. This is the surgeon command system. It gives you a beautiful 3D 4K monitor. If you see in the hands, there are these 2 devices which are used to control. These are called as the hand control devices or the gimbals. The very important system, the safety feature, is the head tracking safety feature. When we sit on this console, we wear a goggle, and if I look away from the screen at any time, the instruments will freeze. If at any time the instrument is not in vision, it will pop up on the screen. So all robotic systems come with very robust safety mechanisms which prevent any accidents, and this is the vision card. Now, I will just take you through how the system of SSI Mantra works. These are the gimbals in the hands, and this is how the patient arms are working. So aside from up and down, side to side, you are also able to do 3 movements which are called as roll, pitch, and yaw. So you are able to turn the instrument up and down, side to side, and even rotate the tip. So up and down, in and out is the same movement what we see in laparoscopy. All laparoscopic instruments give us these two movements. But has any of you tried eating rice with the chopsticks? People who are experts will do it. But this movement of the wrist, this is called as the endo wrist. Yaw is the side to side tilt of the instruments. Roll is the rotation of the instruments. This is very, very useful where you are working in tight corners. So you are working with multiple fibroids, you are on the sides of the patient. So this yaw, pitch and roll and this endo wrist is what makes robotics so much easier, so much fun and so much more accurate and precise. Now, if you compare the systems that are there, the Da Vinci has Xi and it also has a new single port model. It has got a prohibitive cost, but it has got the largest data. It has been around for almost more than 20 years and it has got the largest data possible. The CMR system also has a smaller footprint. It is modular. Plus, the CMR system used to come with varying cost options. So you can rent it, you can charge it per case. And so a lot of us bought the CMR system on rent. The SSI Mantra has got more bigger, arms. So the footprint is bigger, but the advantage is that it can be used for cardiac surgery. It can be used for almost every specialty. CMR cannot be used for cardiac surgery. Hugo Ras from Medtronic is another system, and the latest system what has come is the MedBot. All of you would have seen Dr. Jay Mehta from Mumbai has recently put an order for MedBot. MedBot is also a system which allows telerobotic and it is from China. It is yet to get some regulatory approvals, but once it comes, I'm sure MedBot and SSI together will really change the face of robotics in India. So here I'm just showing you the steps of a robotic hysterectomy. The first step is the draping and the docking. So the lower part of the arms always has to be draped. The upper part of the arms is unsterile. The lower part always has to be draped. The draped has to be reused at every time. So first you give anesthesia to the patient. The ports are inserted and then you bring in the C. The C arm is the camera cart. 1 and 2 are the instrument carts. Now this is the port placement. The port placement is higher. We put it at least 4 finger breadth above the umbilicus and the rest 2 are placed in a semicircle 8 centimeter away from the center port. Now you can see this is the instrument which is getting attached to the robotic arm. Now the camera has been inserted. The instruments are longer. They are attached to the arm. And now we are starting the hysterectomy. The steps of the hysterectomy remain the same. We always start with the round ligament. The energy sources what are available to us, what were available to us in the intuitive system were only bipolar and monopolar. In the SSI Mantra, we also have the harmonic. And I will show you a hysterectomy which we do with a novel vessel sealer. That is called as, that I will be showing you in the next few videos. So we are preserving the ovaries. On my left is a grasper, a bipolar grasper. On my right is a scissor. The scissor can be attached to a unipolar energy source. So it can also be used for unipolar coagulation. The same steps being repeated on the left side. Few differences what are there between laparoscopy and robotics is that you cannot just quickly take out and take in the instruments. The instruments are attached to the robotic arms. So whenever you want an instrument change, your assistant who is standing by the patient has to remove it from the robotic arm and then insert another instrument, click it in place, advance it, and then only you take the controls. The advantage is that when I started robotics, I was wondering because we are used to using harmonic so much that whether I'll be happy to use the monopolar and the bipolar. But eventually I realized that the monopolar is very, very accurate. Here, this is a patient of previous cesarean, but you can see literally we can do a fiber by fiber dissection. The one thing which you will not get in robotic is the haptic feedback. So when you touch, you will not be able to make out whether it's a hard tissue or a soft tissue, because actually you are just holding the gimbals. It is the robotic arms which are going here and touching the patient. So there is no scope of any haptic feedback to you. But the 3D vision and the magnification will make up for it. So there is a virtual haptics or a phantom haptics which is there because you are able to see so well. So your mind can actually probably touch it in your imagination. Now, so this is the uterine artery. We are using only the bipolar and unipolar and the final colpotomy. For colpotomy, just notice that I am using a scissor with a monopolar attached to it. And it really cuts very well like a knife because the tip is very sharp. So we get a very narrow spread of the energy. And finally, we remove the specimen and do the endosuturing. So this is robotic hysterectomy. Robotic hysterectomy is nothing new. Many of us have been doing robotic hysterectomies. What I like or what I'll go step by step is this instrument called as the expert seal. In my left hand is the expert seal. You can see it is sealing as well as cutting. So it prevents one instrument change, and that is why I just love this instrument. It is recently developed by SSI Mantra. The one good thing about SSI is that their speed of working is very fast. So they have, within a span of 2 to 3 months, they have developed not only the harmonic, but also the vessel sealer, which is the expert seal, which I am using. With the use of the expert seal, you can see our coagulation has become much more accurate. This hysterectomy is our 4th or 5th, and it is practically bloodless. I have been a laparoscopic surgeon for a very long time. The difference what I find in robotic hysterectomy is that you actually are going fiber by fiber. The camera is in your hands. So whichever part you want to magnify, you are able to do it. Whichever part you want to centralize, you can do it. Now the left side pedicles are done. Now coming to the right side pedicles. To right side pedicles also the same way. And then the most important, which is very beautiful in robotic hysterectomy, is the bladder dissection. In bladder dissection, because we are now getting mostly patients who are previous cesarean or previous 2 or 3 cesareans. We have done 15 hysterectomies so far, and almost I think 12 of them have been previous 2 cesareans with stuck bladder. There are 3 techniques that we use. One is the lateral window technique. So it is the same what we do in open hysterectomy or in laparoscopic hysterectomy. That is, we coagulate the uterine arteries, and then under the uterine arteries, we try and dissect and push down the bladder. So here we are just coagulating with a simple bipolar forceps, the uterine arteries. Not using a sealer or anything here. All of you can appreciate whenever I want to zoom in, the camera is in my control. So I can always centralize and always go wherever I want to go by myself. There is no tremor. The camera is very, very steady at all times. Sometimes your assistant is holding another instrument or is distracted or somebody is talking to him, and then he is not able to show you the camera properly. But that is not the case. The camera will be exactly where you want it to be. And overall, the surgery is going to be much more exact. Now for the colpotomy. So starting from the anterior vaginal vault, we always start from 10 o'clock and then go laterally. The cautery setting is around 25 to 30, same what we keep in laparoscopy. Here always we have some descending cervical vessels. So here always we use a bipolar to make sure that eventually there is no vessel which gets retracted and starts bleeding. Finally, the walled suturing. We use 15 centimeter barbed suture because it is much quicker that way. Suturing in robotic hysterectomy is much simpler because your instruments are able to move. You can go in any ways. You can go front to back, back to front. So that restriction of long instruments which are stiff is not there. So suturing for anybody who does open surgeries, suturing is almost similar in robotic because you are sitting at the center and you are operating. Plus, you can go to the depth. You can really go as deep as you want in robotic. This is our data. And of the 15 cases that we have done, just imagine the first case we took 3 hours and 19 minutes. It is down to now 45 minutes of operating time. Most of the patients, for the first time when we did, we kept her for 4 days. But now we discharge on the second day. So this is very good because this data our robot gives us. So we are able to see if we are improving on our docking time, console time, suturing time, and everything. Now coming to the exciting thing which is there, that is the telerobotics. What is telerobotics? So telerobotics is a remote surgical control via robotic platforms. So in telerobotics, the surgeon is at a different place, the patient is at a different place. What is connecting them is a high speed and low latency network. It can be a fiber network or it can be a 5G network. Why it is an advantage? Because it can open up a plethora of options for you. Whenever you are stuck, you can call in a surgeon on phone. He can sit on his console and he can guide you through the steps which are difficult. For example, robotic cardiac bypass is very challenging. There are very few surgeons who are able to do a coronary anastomosis robotically. Dr. Sudhir Srivastava recently performed a robotic telesurgery wherein the surgeons from the hospital, they did the thoracotomy, they prepared the vessel, and he just came in and did the anastomosis from Delhi. So imagine, this is really mind-boggling for all of us who never thought this would be possible in our lifetime. The good thing is that it has got all the approvals. So CDSCO is the body which approves all the novel devices and instruments, and SSI Mantra has been approved by CDSCO for telesurgery. Successful telesurgeries have been performed in India as well as from France to India. So Dr. Sudhir Srivastava operated a cardiac patient and ASD repair sitting in France, and the patient was in Indore. Dr. Mohit Bhandari has operated obesity case sitting in France, and the patient was in Indore again. Now the future outlook is that if you have a very robust 5G network, you are able to integrate AI for safety and decision support. But the need of the hour is standardization of the guidelines and make a medico-legal framework. Plus also a very robust global connectivity. There are a lot of challenges. Now how it happens, I'll just take you through it. There are two parts to a telesurgery. One is the master console and the second is the slave console. So what happens is that the patient in the OT is, the port is inserted, the instruments are inserted, the robot is docked. Now there is always a trained surgeon in the OR with the patient who is sitting on the slave surgeon console. Now the surgeon or the master surgeon can be anywhere. The surgeon can be in a bus, the surgeon can be in another hospital, surgeon can be within the same hospital on a different console, surgeon can be in SSI headquarters at Delhi, and he will be sitting on the master surgeon console. Now these two will be connected to each other either with a fiber network. So when we did the telesurgery from the bus, we used the fiber. When we did the telesurgery from Delhi, we used the 5G network which was provided to us by Airtel. Now there are two instruments, one is an encoder, one is a decoder. So this connection, what Airtel gives us is a P2P connection. It's a private connection. No other person has access to that connection. The speed is 100 Mbps. The network latency has to be 3 to 5 milliseconds and transmission latency not more than 40 to 45 milliseconds. Now the master surgeon is on the left side, the yellow side, and he has a decoder. This is attached to a network firewall in the remote location, and then Bharti Airtel through the network, these signals are transmitted to the slave console, and then the slave console is giving these signals to the robotic arms, and the robot is performing the surgery. So on the slave side, there will be an encoder, and on the master surgeon side, there will be a decoder. Now you will ask me, what about the communication between the teams? How does the OT team communicate with the surgeon who is somewhere in other city? This is by a Zoom meeting. So at all times, I have a mic. There is a speaker in the OR. So I am able to talk to my team continuously on a Zoom call. Now, can this network be broken? Can somebody break into this network? No, it can't be, because it's a secure P2P dedicated network which is provided by Bharti Airtel only for telesurgery. Now, has telesurgery been studied? Has it been published? Yes, this is an article in Springer Journal which has been published. The first surgery was done on a pig. That was a robotic cholecystectomy. The second surgery was done between SS Innovations and World Laparoscopy Hospitals. And subsequently, there were some more other surgeries which were done between Rajiv Gandhi Cancer Center and the SSI headquarters. Subsequently, the geographical distances have stopped to matter. Now, after Dr. Sudhir has done a surgery from France to India, now it looks like anything is possible. You just need 100 Mbps, good fiber connectivity, and you are able to operate anywhere in the world sitting on your own surgical console. So this is the traffic plot for transmission network at the headquarters. It exactly mimics that of that which is at the recipient side. So these are the initial 4 cases. But let me take you back 25 years. This is not the first in the world. Professor Mariskov, who is the person behind the famous training institute IRCAD, which started in France but is now in different locations. It is even in India at Indore. Professor Mariskov back in 2001 did the first telecoli, that is the first cholecystectomy. Surgeon was in New York and the patient was in France. Imagine at that time, the network latency was so bad. Look at the robot on which he is operating, probably even before the first generation robot. And still he made it possible. But it took 25 years and it took an Indian surgeon to bring telerobotic back, and with what a bang it has come. We have done the first telesurgery in the world from the SSI Mantra bus. On the right side, you can see I'm sitting in the bus, my console, and on behind you can see the Zoom meeting which is in progress. On the left side is Dr. Amit Tandon, who is the surgeon who is in the OT and who is moderating from the OT, and he is also the backup surgeon, because in all cases you need a backup surgeon in the OT who is well versed with the procedure. So this was the first robotic surgery we have done telerobotically. Now, if I show you the surgery happening, this is my assistant. This is the exact surgery what we are doing. The blood loss was less than 10-20 ml. The entire surgery has taken us maybe 40-45 minutes. And if you see my movements and the end result of it, you will not find any latency. You will not even know if I didn't tell you that this was a telesurgery and surgeon was not inside the OR while operating. So I am able to communicate with my OT team at all times. The OT team is able to communicate with me. I forgot for some time that I was not in the OR, and I really felt as if I was there near the patient performing the surgery. Now for the bladder dissection, so you can see the cup, the white rim coming up. The uterine arteries have been taken. The OT team is there. One laparoscopic assistant is always required for suction, for inserting the suture, for removing the suture, and all of this. So practically we do 2 ports, and 1 laparoscopy port is always required in all robotic procedures. Now this is the colpotomy. That is the cup being seen. Now, because we use the scissor, it has a very fine tip. It would be interesting to all of you that when robotic hysterectomy started, they found that vaginal cuff dehiscence, the incidence was very high in robotic surgery. The reason was that probably they were cooking the vault too much. They were probably using too much energy on the vault. But that is not the case anymore. There was even a class action suit on robotic surgeons because of the vaginal cuff dehiscence. This was almost, I think, 10 to 15 years ago. Now, this is the specimen retrieval vaginally. And finally, we are going to be suturing the vault, and that is the end of the story. Now, once you get used to these instruments which can twist, turn, go anyway, you really cannot go back to, or it is little difficult to go back to laparoscopy. Finally, we took one bigger, bolder step. We decided, let us do a case in Bhopal, sitting in. Yes. So I visited the SSI headquarters in Delhi. This is the SSI headquarters. Here we are connected by Zoom meeting. This is the headquarters where they have a telesurgery center. The patient is being now prepared. This is the PC card and that is the conclusion of the surgery. And this is where across 700 kilometers we are going to perform this successfully. Finally, a brief note about suture technology, vaginal cuff closure. So, it's always easier to use barbed suture because no knots are involved. Plus, it is self-anchoring. So, it gives a better support and it gives a better apposition of the vagina. So, we have stopped using traditional Vicryl. We use barbed suture in all the patients. Now, ERAS protocol, same-day discharge in robotic hysterectomy. I'm still on the learning curve. So, we still discharge on second day. But there are patients who can be discharged on same day if the duration of anesthesia is less. Now for the next wave. The next wave is that because now surgeon can be anywhere, the machine can analyze all your data. So if you marry robotics and artificial intelligence and you feed a lot of data into it, you will be able to get so many insights which actually help refine your surgery. The day is not far where my student can be sitting in a remote city with her robot and I can take over the surgery at any time whenever she has a difficulty. I can do telestration. I can, in fact, take over and do the difficult step and then leave the remaining surgery to her. So this is almost a reality now. So this is all I think what we should be looking for. What is also exciting is that now SSI Mantra also has ICG mode. So you are able to use and see the ureter. Now, what I told you, digital dashboard for surgeon feedback. And so this is going to be the digital surgery ecosystem. You are able to save all your videos on cloud. You are able to track your workflow. You are able to benchmark. You are able to get dashboard and metrics. Now, the exciting thing is the AR overlays. Many times when we do myomectomy, we keep on going back to the reports and seeing the fibroid, where it is, where was the second fibroid, where was the third fibroid. Now you can do an AR overlay and in your screen, you will be able to see the fibroid where it is. You will be able to see the endometriotic nodule where it is. And this is going to be a reality in the next 1 year. We are already working on this project with 2 companies. So advanced imaging, augmented visualization, and artificial intelligence will help us to go to telementoring and remote surgery. plus global platforms for cross-institutional training. So now the future outlook is that we are going to shift from manual robotics to intelligent robotics, integrate AI with AR, and the next wave will be advanced imaging, artificial intelligence, telementoring, and remote surgery. However, I think telementoring and remote surgery is already going to come in 2025 or 26. It will not take so long. So the future need, which I want to throw a question to everybody here, all the seniors, all the esteemed teachers, chairpersons, we need the national guidelines for telesurgery under NMC and Health Ministry so that we can do it in a proper way, taking all the ethical, medico-legal and safety precautions into view, standardized consent, legal clarity. Our legal advisor has helped us draft a very good consent for telesurgery, but we need a consensus on this. And so the next frontier is robotic surgery. You are going to enhance patient outcomes, surgeon capability, and the future definitely looks more accessible, affordable, and AI powered. Thank you so much.
Thank you, Priya Garu. So first of all, I congratulate you. So for being learned so many new advances on robotic surgery. How many you did tele-robotic surgeries?
So far in India, more than 50 tele-robotic surgeries have been done. We are two gynecologists. The first surgery was done by Dr. Leena Malhotra. She is from Muradabad. So she has done from Delhi to Muradabad. We have done over the longest distance, that is from Delhi to Bhopal. So far only two gynecologists have done the telesurgery.
So very much hearty congratulations to you. What is meant by RAL? You need not take any assistance from laparoscope. You need not combine club with laparoscope. There is no necessity at all.
So essentially, robotic surgery is a laparoscopic surgery. So you always need the laparoscope. But every robotic surgery is a robotic assisted surgery because robot is not doing the surgery. The surgeon is doing the surgery with the robotic assistance. In all robotic surgeries, there is always one port which is in the hands of the bedside assistant. This is for suction, this is for inserting the suture, this is for removing the suture, this is for hemostasis sometimes, this is for retraction. So all robotic surgeries, we always will still require one laparoscopic assistant on the bedside of the patient.
The camera is in hands of main surgeon.
Camera
That's
is in the
advantage.
hands of totally in the control of the main surgeon.
Again, just I am having one doubt. What the difference between traditional braided and your usage of suture material? Traditional bob and
So in the traditional vicryl, there is no issue.
Traditional bob suture.
No, I'm using traditional barb suture.
Traditional bob. You are telling some advantage over that of traditional bob, some other suture material.
It is a longer absorbable, delayed absorbable, but I think for vaginal vault, it's a mucosa. We really don't need a delayed absorbable. For bobble and for some other this thing, I think that is that may be used. I have very limited experience with the new barb suture.
So as per these recent advances, definitely you have to take only shorter time when compared to normal laparoscopic surgery. Definitely. You are telling only 45 minutes it is enough to complete.
No, on the contrary, we have taken longer than what we need for laparoscopy because there is a little learning curve for the team also. So our normal, we add at least 15 minutes to the laparoscopic hysterectomy time for robotic currently. Eventually, as our team gets better, I think we'll be able to shorten this, but currently we take longer for robotic surgery.
So thank you very much. And Dr. in time also it is completed. Very nice topic. I congratulate Monica Singh also for having given me this opportunity. And very good applause.
Thank you. Thank you.
Thank you.
Thank you, Priya. That was really, I mean, every time we listen, we enjoy your lecture,
Nice.
the visuals and your experience.
Thanks.
I think I was listening to somebody that the most effective speakers and the most effective talks are those where you speak about your life experiences. And that reaches the audience very fast and that makes an impact which nobody can forget for a very long time. So I think Priya has, started the way forward and we will have a lot of robotic surgeons in the making. And I feel this is the future. And the faster we embrace the future, the easier life becomes, and we know we can always combine traditional with modern and reach an optimum balance. So I think today's webinar, we dealt with two starkingly opposite scenarios. One wherein a senior government doctor is telling us not to do unnecessary hysterectomies. And the second one, young gynec, she's telling us how to do robotic. But it is the right mix. They are clashing topics, but I put them together so that you know what are ethics, what are regulations, and what are the advancements. So I hope you all enjoyed the two talks as much as we did. And I am again so grateful to Kurnool, Vijayawada, and Kanchipuram Society, especially Prabha ma'am, teacher of teachers, for being there. Radha for spearheading the whole project, because Radha was the first one I talked to when I wanted to involve the South Zone, besides being a very great friend of mine. Of course, Shabana held the fort with her panel discussion. Priya, I was very glad to have her as a speaker, and Dr. Archana Mishra, of course. So let us, just go ahead. And now you will have the practical case scenarios. You will have Dr. Shabana, Dr. Nishi, and Dr. Nandini bombarding you with questions as to whether you've done a hysterectomy for the right indication or not. Thank you so much.
Priya, very nice talk. Priya.
Yeah, very nice talk.
Thank you, Didi. Thank you so much. Thank you for giving me this opportunity again.
Thank you so much, madam.
And Synergy is the only series where there is no timing for a lecture. When you feel your lecture is a particular minutes, 25, 35, 45, it doesn't matter. You have to speak your heart and you have to speak the complete lecture as long as the audience is attentive. Thank you so much.
Yes.
So moving towards our panel discussion, that is on hysterectomy correct clinical profile based indication. To moderate the panel, we have Dr. Shabana Sultan ma'am, Dr. Nishi Mitra ma'am, Dr. Nandini Singh Bhati. Dr. Shabana Sultan ma'am, madam is presently professor and head of the Department of OBGY at GMC Bhopal. She is presently vice president of Bhopal Obs-Gynae Society. She is a very active member of our Bhopal Obs-Gynae Society with lots of publication, and she has presented lots of paper in national conferences. We welcome you, ma'am.
Thank you.
Next, we have Dr. Nishi Mitra, madam. Madam is presently professor of Ellen Medical College, Bhopal, with a vast clinical experience of more than 1 decade. And she has a special area of interest in high-risk pregnancy and oncology. We welcome you, ma'am. Next, we have Dr. Nandini Singh Bhati. She is presently assistant professor in OBGY department, GMC Bhopal, and also coordinator with me in this program. And she is trained in high-risk obstetric, antenatal, and gynecological ultrasound with special interest in reproductive medicine and gynec malignancies. We welcome.
Thank you, ma'am.
Now moving towards our panelist, we have Dr. Annamula Sridevi madam. Madam is presently associate professor in OBGY department, GMC Ongole, and is gold medalist. We welcome you, ma'am.
Our next panelist is Dr. Baby Shalini madam. Madam is currently the consultant and managing director at Shreshtha Hospital. She is also the secretary of Chittoor Obs-Gynae Society. Welcome you, ma'am.
Next, we have Dr. Kavita Batula, ma'am. Madam is presently senior consultant OBGY and laparoscopic surgeon at Vijayawada. And madam is gold medalist, and her special area of interest is laparoscopy and hysteroscopic surgery. We welcome you, ma'am.
Our next panelist is Dr. Lata Venkateshwar madam. Madam is a consultant at Sundaram Medical Foundation, Chennai. And she is a very well-known gynecologist. We welcome you, ma'am.
Next, we have Dr. M. Vijaya, ma'am. Madam is presently senior consultant at Vijayawada Rainbow Hospital, and also she is alumni of Osmania Medical College, Hyderabad. We welcome you, ma'am.
Our next panelist is Dr. Somlata Rapati, madam. Madam is currently the secretary at the Vijayawada. Madam is consultant in Obs-Gynae in Valga Nursing Home, and she is also the secretary of Vijayawada Obs-Gynae Society. We welcome you, ma'am.
We have Dr. Uma Devi Rala, ma'am. Madam is presently secretary of Tirupati OBGY Society and a very senior and experienced gynecologist of the town. We welcome you, ma'am.
Our next panelist is Dr. Radha Lakshmi Madam. Madam is presently working as a professor in department at Santiram Medical College, Nandayal, and she has been a hardcore academician with numerous gold medals to her credit. She is the alumnus of Kurnool Medical College and she has an instrumental role in placing all in this organizing this webinar today. Thank you so much, madam. We welcome you. Our next panelist.
Next, we have Dr. Varuna Pathak, madam. Madam is presently professor and head of the department in RKM Medical College. She is an obstetrician, gynecologist, speaker, as well as writer, and she has authored recently a book that is on midlife crisis, Lost at 40. She is actively involved in CME's public health forums and has received various multiple awards at national level. We welcome you, ma'am. Now I hand over the session to our moderators, Dr. Shabana ma'am, Dr. Nishi Mitra ma'am, and Dr. Nandini.
At the outset, I'm very much thankful to Dr. Monica Didi and the entire team, Dr. Purva and Nandini, for giving us opportunity. And I think the screen sharing will be done from Nishi. Nishi, you are ready?
Yes, ma'am. I'll be sharing
Yeah.
the screen shortly. Is it visible?
Yeah, it's visible.
So,
Purva,
very
may I
good
know
evening.
that how many panelists have joined? Can all panelists have joined the webinar?
Ma'am, I'll just let you know. Ma'am, there are 7 panelists at present.
Okay.
Should I start, madam?
Yeah. Nishi, please start.
So, very good evening to all the dignitaries, and I feel very privileged to be here on this platform and talking about a very important topic, that is hysterectomy for benign gynecological conditions, guidelines and advances. So, to start off with the session, we all know and have been discussing that unnecessary hysterectomies has become a great menace, not only in India, but I found articles where people are reporting that this is a paper from Italy, and it also reports that unnecessary hysterectomies are taking a toll. Then there was a case report of unинdicated hysterectomies in India that was published in BMJ, talking about a 24-year-old woman who underwent hysterectomy. So, am I audible?
You are audible.
Yeah, so that was a case of a 24-year woman who underwent an hysterectomy for just vaginal discharge, and she had immense surgical medical complications later on, which was very distressing for her. So I hand over the audio to Dr. Shabana ma'am for the first case.
So actually, we have chosen very practical cases, and we know that the topic is quite vast, but few indications we have chosen which are really very important to highlight. So my first case is she is 29-year-old woman. She is para 3, live 3. She reported to gynecological OPD with cervical biopsy report showing CIN1. As we all know that we are more and more focusing for the screening of cervical cancer after 25 years, various guidelines, and in the Government of India guideline, we are going after 30 years for the universal screening of the patient coming to gynecological OPD through various methods like VIA, like colposcopy, whatever availability is there in that particular institute, pap smear. So if we are finding various reports like in the colposcopy, also by the Swede scoring and by the Reed scoring, we calculate SIN1, SIN2, and SIN3. And in this particular case, she is presenting with SIN2 and she is very much anxious because now we are publicizing that yes, you should be aware of your uterine cancer. बच्चेदानी का कैंसर इज रियली वेरी इंपॉर्टेंट जो हम महिलाओं में जागरूकता बढ़ा रहे हैं तो वी आर ऑन द वन साइड वी आर इंक्रीजिंग द अवेयरनेस दैट इज रियली very important because now in our center also we are getting patients in early stages. That's a good thing. But on the contrary, some other doctors, they are taking advantage of this particular thing. That is, if the patient is having a fear of cancer, they motivate patients for going to the for the hysterectomies. So she is very much anxious and that she may have cancer in future, and how she had to get her uterus removed urgently. What happened next? Next slide, please. So I have a question to my panelist. Any panelist can answer. Is hysterectomy is the standard care of SIN 2 or SIN 2 plus? And what are the conservative options which are available? So I don't know what are the, who 7 panelists are there. I just voluntarily want answers.
I am Dr. Uma, ma'am. Yeah, I'm from Tirupati.
Yeah, Dr. Uma, welcome.
Yeah, good evening, ma'am. Good
Yeah.
evening, ma'am. No, actually, for the status of hysterectomy for SIN 2, no, ma'am. Actually, we do get a lot of cases with the SIN 1, SIN 2, SIN 3 in our hospital. Ours is a government hospital, ma'am.
Yes.
But we go for ablation procedures only. And ablation procedures, definitely. We are doing LEEP, LEDs, thermal ablation. We have a associated Tata Cancer Institute where they have given devices for us for ablation also. So to prevent unnecessary hysterectomies also. So we have both the thermal ablation devices and we do LEEP and LEDs also. So I do think that if colposcopy is adequate, we can go for excision and ablation. So we're not proceeding for hysterectomy
Yes,
as
so
such,
this
ma'am.
is the one message we want to give here in this forum, that in a young patient, she is coming with SIN 1, even to SIN 3. I mean, SIN 2, say plus B if it is there, like the lesion is SIN 3 also, then hysterectomy is not at all indicated. We have other options like thermal ablation, like cryo, like we can go for the SIN 2 plus, LEDs and LEEP. So this is actually a chart of GCPR, which is showing that if the patient is going for a pap smear or any type of triaging with cervical cancer screening and the colposcopy or lash biopsy is showing SIN 1, SIN 2 and 3, we have other options available. And we have set criteria for doing thermal ablation and cryo and LEDs. So my next question is, that what are the clinical considerations are to be kept in mind when we are going for the ablative procedures? Any other panelists can answer, or also for the excisional.
Yes, ma'am. I'm Dr. Lata from Chennai. Actually, for
Dr.
ablative procedures, definitely we need biopsy. If it is of an excision procedure, that will be better because we may look into the biopsy specimen and we can see whether it is really CAN2. If it is pap smear report, then excisional procedures will be better. For ablative procedures, definitely the lesion should be clearly visible. That is very important point. Then it should not involve the endocervical region. Sometimes the probe we use for thermoablation or cryotherapy may not reach endocervical region. So that is another point. Then it should not be a invasive cancer or visible growth at the mouth of the uterus. So these are the things, and adequately we have to cover all the abnormal areas while we do the procedure. So these are the criteria we have to take into account while we go for a conservative management. And after doing this kind of a procedure, definitely patient need follow-up also. We can't do the procedure and leave the patient. So we have to advise. It is very important to do counseling and call for the patient for follow-up, because always there is a thing in their mind that they are getting treatment for cancer, but it is just a pre-cancer lesion. So we have to counsel the patient properly for adequate follow-up in future also. So that is very important point when we go ahead with
when you call for the follow-up, madam.
See, actually, usually in our hospital, we call after 6 months. Initially, after a month to see how it gets healed and everything. Then after 6 months, just to have a look at the cervix. Then for the definitive procedure like repeat pap smear or combining it with the HPV DNA or for colposcopy, we call after a year.
Yes. So that is really important. It should be transformation zone 1 and 2. It should not go inside the endocervix when we are planning for the ablative or for the cryotherapy.
Like what I would prefer is like she's a young patient, and if I'm very confident of a SIN2 lesion and the cervix otherwise is also not looking suspicious, and yes, it is fulfilling those criteria for an ablative procedure,
Yeah,
then my first choice would be an ablative
yeah.
procedure.
Actually, Varuna, we have actually given the biopsy report. That's why we have a tissue available.
Huh.
So we
So
are not
I would
preferring excision. For this young
Exactly.
patient, I also prefer for the ablative only.
Huh.
If it is fulfilling all the
Yes.
criteria. Yes.
Yeah.
I
Right,
agree.
right.
Yeah. So I just want to ask to the other panelists that what do you mean by screen, triage, and treat approach, and what do you mean by screen and treat approach, just for the sake of the audience to understand.
Hello, ma'am. I'm Dr. Somlata from Vijayawada.
Yeah, Somlata.
Yeah. Screen trials and treat means like first we are screening and they're keeping them in the follow-up, and if at all treatment is needed, we are going for the treatment. And in case of screen and treat, there itself we are just like if we do visual inspection and if it is negative, it's okay. We ask them to come for follow-up after 3 years. And if at all positive in the same setting, if she is suitable for procedures, we can go for ablation. That is either dermal ablation, and again we definitely have to tell for follow-up. And in the case of where if the patient is not suitable for ablation, we advise for LEEP or LEDGE procedures. And if the in that, if it is okay, it is less than only SIN2 or SIN3, we advise them for follow-up. If any suspicion of malignancy is there, if we have to advise for hysterectomy as a routine. And in case of suspected cancer, we know like we have to go for biopsy. And in the other case where we are going for HPV DNA, now the primary thing is we are doing HPV DNA, and if at all positive, we go for visual inspection. And in that, if it is okay, we will just leave it. And if it is anything suspicion is there, then go for ablative procedures. And in case of triage, where positive only, we are going for colposcopy or biopsy. And if at all comes as a cancer, we have to go for surgery. And in negative cases, where in the triage, if HPV is negative, re-screen after 3 years.
Yeah,
And if at all
correctly mentioned.
if positive, go for a colposcopy.
Okay.
Means like going screening and treating or screen, triaging and treating. Best is always triage and treat.
Yeah,
So
but in various
that is
situations,
where I
actually, it's
wanted
really
to give my
suitable to go for screen and treat. In some situations, like if the patient is not, you know that this patient won't come for the follow-up, then it's better to catch her.
we have to
Better to catch her and then screen. What we are
treat.
doing in our setup, we are doing a screen and treat.
So
Directly we
Dr.
catch the patient and treat.
No, but actually what she said very rightly is that
Explain
when
the patient first strict follow-up.
Explain is really very important.
See, ideal is
Document.
screen,
Everything
triage and treat.
Yeah.
है ना, Dr. Sonlata. So what is ideal is screen, triage and treat. But as Dr. Shavana is rightly putting it up, if you are not sure that it's a low resource, it's
then
too
definitely-
overburdened hospital, or patient may not come for follow-up, then it's always good enough to screen and treat right away. Yeah.
So my another question is to my other panelists, like what are under what circumstances hysterectomy is indicated in such cases when SIN2 and SIN3 is coming and you are going for other option also, but yes, now you have to plan for the hysterectomy. Any other panelists can answer.
Nobody wants to.
Varuna, you can answer.
Actually, when the patient is not able to come for the follow-up.
Ji, madam.
Yeah, definitely we have to advise them to go for a hysterectomy because they may lose the life because of the cancer. So we have to assess how far the patient will be able to be followed up. Sometimes if the patient is coming from very remote village, so she is not able to have an adequate follow-up, definitely we have to go for a hysterectomy. It is better for her life than not coming up, leaving it and getting into cancer. That is one of the most important indication in that. Then sometimes we may miss the lesion. In case of, according to Bethesda, the pathology has been grouped into low grade as well as high grade. There is no CAN2. So CAN2 and 3 are grouped under high grade lesions. So whenever we get high grade lesions, we have to see whether it is associated with HPV DNA. If HPV DNA positive and high grade lesion, and if we suspect there might be carcinoma in situ or invasive cancer, sometimes it is better to go for a hysterectomy. Otherwise, if we like to retain uterus, cone biopsy, further follow-up, it's a lot of thing for the patient. So, and she has to spend a lot of money on that for the procedures, follow-up, everything. So, if it is of going to carcinoma in situ, or if we think that it might be invasive, then it is better to go for a hysterectomy in those situations, high-grade lesions.
Okay. Any other thing you want to add, Varuna?
Same as what Madam put it rightly. And
Yeah,
if
the
there is
follow-up
a
is
clinical
really very
suspicion,
important because
if
you
your
want-
clinical suspicion still tells you that something is not right and you are in doubt, then it is better to save the life of the person rather than, save the
Yeah,
uterus.
even in your follow-up visit, if you are suspecting कि नहीं ये तो गड़बड़ हो रहा है, then you can plan for.
Yeah.
So
Very right.
we go for the another case, Nishi.
Yes, ma'am.
Yeah.
So this is case number 2, and it is about a 45-year-old para 5 live 5 with previous 2 LSCS who presents with a complaint of heavy menstrual bleeding for 8 months. And her hemoglobin is 8 gram per deciliter. The transvaginal USG shows endometrial thickness of 16 mm premenstrually and a subserosal fibroid type 7 of 2.5 centimeter. Her BMI is 21. She has no other significant medical history, and she requests removal of uterus as suggested by a local practitioner. So the question for the esteemed panelists is, what further evaluation is necessary before deciding on hysterectomy?
Yeah, good evening, all the panelists and moderators. Myself, Dr. Radhalakshmi.
Good evening, madam.
Secretary, OBG, Kurnool Society. Presently working as professor. So we do, whenever the patient is more than 40 years, we definitely do endometrial biopsy. And less than 40 years, when there is continuous and irregular bleeding PV, and the endometrial thickness more than 12 millimeters, family history of malignancy, that is mainly endometrial cancer, ovarian cancer, and colonic cancer, and history of diabetes mellitus, hypertension, PCOS, obesity. In all those cases, we prefer to do endometrial sampling. The endometrial sampling is mainly done with PIPLA, not done with DNC. And if preferable is to do histoscopic guided biopsy, especially when there is suspicion of endometrial malignancy, depending on the history or TVS features suggestive of some polyp or local pathology.
Very nicely explained, ma'am. This is very important that every woman presenting with AUB above 40 years should first undergo endometrial biopsy before embarking on any kind of definitive treatment. So this point has to be taken into account. Now, the biopsy was done, and the biopsy report of that patient denotes endometrial hyperplasia without atypia. So now is hysterectomy mandatory in such cases is the point of discussion.
No, it's not mandatory still. Still, it is not mandatory.
Yes.
So yes, there are less than 5% chances that it may progress to pre-malignant situations. But just at the word of atypia, like without atypia, hyperplasia per se is not an indication. Because what we know is that a lot of these lesions will regress and they can easily regress. So only that for that 5% to proceed with a hysterectomy is well not justified. I would want to put her on progesterones. And like in my clinical practice, I've had beautiful results, especially for these type of women with LNG. LNG, you put in at 45, you put in an LNG, she's bound to land up wind up with a menopause by the time the tenure of the LNG comes to an end. And it is well documented with good level of evidence that LNG will reverse most of the atypias, like the hyperplasias.
Yes.
So I'm very comfortable with the.
Yeah, so this is the take-home message.
Follow-up
That
is
if the
important
patient is
after
coming
6
without atypia, that hysterectomy is not at all indicated. We can go for the other option. But follow-up is really important.
Still, yes. But at no point should you, not keep her on transvaginal scans regularly.
Ma'am, what about the pathologists reporting as other than this hyperplasia? Even though the guidelines say that pathologists should report hyperplasia without atypia and hyperplasia with atypia. These are the recent guideline that the pathologist has to report. But still, many a time, the clinicians face the reports like proliferative endometrium, mainly disordered proliferative endometrium. Yeah.
So, ma'am, you can complete.
Yeah. So all those things. So disordered, what I think is even the disordered proliferative endometrium also should be considered abnormal, and patient should be treated with progesterone. And that too, when we start progesterone, it should be continuous. It's not withdrawal. Like give for 21 days, get a withdrawal, but it does not help most of the time. So we have to do and counsel the patient to take the progesterone for continuous 6 months. That will give good results than intermittent progesterone.
Ma'am, what is the best to be done in such situations is, one is that we always work in our own team. So it's like you've done a hysteroscopy yourself, you've taken the samples, and your pathologist has to be on board on the same page as you are. So one is that always communicate to your pathologist. You tell them that I want the report in this terminology. So it like there has to be a consistent team.
Yeah,
But
I understand because
but
I
then
work
you are very right,
hospital.
ma'am. Ma'am,
Yeah.
you're very right. They will provide you with all fancy terms under the sky, indefinite, indeterminate, got disordered. And
They're mostly writing, Varuna. She is right. Mostly they even
So-
in medical college, we have to send it again that they are writing disordered. They are not using without atypia. With atypia until unless we communicate.
Yes. So what goes well also is that hysteroscopy appearance that you had seen. And then you can also be, have an idea as to where are we embarking. But yes, whenever in doubt, two golden rules. One is keep them on continuous progesterone, two, keep them on a follow-up. So you can't lose the patient.
Yes. We can't afford to miss cancer.
ma'am.
That is the
Yeah.
thing in this situation.
And then, of course, ma'am, then the backdrop, the patient that Nishi madam has presented to us is a lovely, sweet little thin-built girl. But in practice, we are not getting these lovely girls anymore. Most of them are obese, hypertensive people. So if the backdrop suggests, then also we keep our red flags on.
Yeah.
Yes, ma'am. We
Sometimes
have to
these women
continuously
having-
monitor them.
Yeah. Sometimes with these women having background comorbidities, as literature says, 1 year progesterone is not enough. So we have to continue
Even
to
they are
give
having
progesterone.
family
Otherwise-
history. If they are high risk, they are having family
Families.
history of endometriosis.
Ma'am, the guideline says put LNG
According to
IUS.
guideline,
Yeah,
we have to
LNG is
continue
very
the
ideal.
progesterone if
Yeah.
the BMI is more than 30. It should be a continuous progesterone.
Yeah, or otherwise LNG IUS will be
Good
working
option.
for 5 years.
5 years, yeah, that is very ideal. Yeah.
And they say that it creates amenorrhea. I mean the hyperplasia regresses and the symptoms are also elevated. So
But
again,
LNG
And
takes
all these
time.
AUM patients usually with progesterone only they get symptomatic relief, even though the report is normal. Sometimes, like borderline.
Sometimes, yeah, that is also true. Yeah. In
Though
clinical
yes,
practice.
keeping them on LNG for the first 3 to 4 months is a task. Oh my
Yes.
God, I am still facing like bearing with people. I've inserted LNGs way back in March. Until yesterday, there is this problem of spotting. It's difficult.
Yeah, it is there in initial 6
But
months.
but it's still worth it. I believe it's still worth it.
Worth it.
It takes time. It needs lots
Yes,
of
ma'am.
counseling because it
Yes,
takes time
ma'am.
to settle. 6 to
Yeah.
8 months for some women, even up to 1 year.
but
I
then
know.
those patients
Some
become
women.
very happy, ma'am, later on.
Later on, they're very
definitely.
happy. Very right.
They are very
Later
happy.
on, later on,
True.
they bless you.
So can I, madam? Whenever you give even do Marina insertion, you can follow them with 3 months of OC pills. So that they don't have intermenstrual bleeding or breakthrough bleeding like that. So that they will be comfortable by that time. The Marina will take over its action. So most of the times I prescribe OC pills for 3 months along with Marina.
Yes, ma'am.
That is a very nice tip, madam, given from you.
And so many of these patients are gynecologists. No, Varuna, Nishi, Shabana?
Yeah. Yes.
So many gynecologist colleagues, they are so happy with an LNG and they can shuffle between work and home and kids, everything with the LNG.
So I think we have had a lot of discussion. So this question is again we have discussed.
So the question with me regarding one question. So some of the times we have to re-evaluate the patient every 6 months with endometrial sampling. So with Marina in situ, how will you do endometrial sampling?
Ma'am, it is through people only. The guideline says
So there are chances of Marina getting displaced if you use people. Have you seen like that? I have a patient Marina displaced downwards with the people use. So
actually, ma'am,
most
yeah,
of the times I want to follow the patients with only transvaginal ultrasound.
The option to go for transvaginal ultrasound.
So, yes, that is again an option that looking for
Madam,
the
even though
endometrial
it is
weakness.
displaced, this is hormone releasing IUD. We are not using it for contraception. So you can keep it as long as it is inside the cavity. Unless it is coming to cervix and the limb protruding outside the cervix, even though it is displaced little lower, it is hormone releasing IUD, we can keep it. Need not worry about it. That's what my opinion is. What about others' opinion?
Ma'am, I have a patient. I have a very, very VIP patient, and yes, it's sunken down a little bit, but I am largely ignoring it for the moment.
Yeah, it is better to keep it because it releases
Yeah.
hormones. So definitely it will help the patient. Need not remove.
You're
because-
right.
I also had a very VIP patient, madam, in which the uterus was almost 4 times the size of that LNG, the uterine cavity. But he needed some time before hysterectomy. So I inserted LNG under ultrasound guidance. I tracked the LNG. It was right in the middle of the cavity, away from the fundus, away from the internal os. But it controlled her menorrhagia considerably. And we could get a good 8 to 10 months before hysterectomy. Then ultimately she had a pelvic kidney and everything. So I referred her to Manisha for lap hysterectomy. So LNG did work even in those huge adenomyotic lesions.
నువ్వు మార్చుకుంటాను ఏని ప్రాబ్లమ్
You know, the menorrhagia part of that, Monica, is taken very care of very well. The menorrhagia for sure settles. The only struggle that then we have is that, that tuk bleeding for 10 days, for 15 days. That's the
Then,
only
like,
challenge.
the top up with OC is the best thing, no?
Is the best thing. Yes, we do tend to do that. Yeah.
Yeah.
వేసేసుకో లేకపోతే ఇప్పుడు ఒకసారి ఆపి మళ్ళీ ఇంకా తెస్తా ఇంకెన్ని ఉన్నాయి
Kavita ma'am, please mute yourself,
Somebody
madam.
needs to mute themselves.
Kavita ma'am, please mute yourself, ma'am. Chalo, let's.
So what the guideline says that what is the follow-up protocol for a patient if she chooses to preserve the uterus. So it is that LNG IUS should be inserted and there should be at least 2 consecutive 6 monthly negative biopsies to be obtained through outpatient endometrial aspiration with LNG IUS in situ. And again, as madam had already, the panelists have already discussed that continuous progesterone therapy is the crux. If we are using it orally, cyclical progesterone should not be used because they are not at all effective in inducing the regression of endometrial hyperplasia. So this is the third case. I am handing over the audio to Shabana madam.
So case number 3 is she's 43-year-old patient and she has come to gynae OPD with the ultrasound report showing submucosal fibroid that is type 3 4x4 centimeter. And her complaints are dysmenorrhea, moderate in intensity and frequent cycle 20 to 23 days with slight increase in the flow since 3 to 4 menstrual cycle. Her sister is having history of very large fibroid, about 15 centimeter 1 year back, and she is very much afraid of fibroid may grow or she may have go for the surgery. What are the options available?
So my question is open to all the panelists. They should give me answer one by one that what are the options you want to choose, whether what type of drug, whether drug or whether conservative surgery. If drug, then what type of drugs are safer?
So even if the fibroids less with the 4 centimeters in size, we can try Mirena for 6 months. So most of the patients will have good results with Mirena itself. So if not, they can go, if they don't want to go, if they have completed childbearing age group, so you may opt for hysterectomy. Otherwise, we can give them medical treatment, especially uripristal assisted. When as such, we have to exclude
So
liver.
what is your practical experience of uripristal?
Yeah, I used a few cases, but with caution, I have not used not more than 6 months, madam. So 3 months followed by 1 month gap, doing all the LFTs, then followed by 3 months course. Even though in according to guidelines, we can use up to 6 cycles of uripristal acetate. I have used only for 2 cycles. Patient had good symptom relief, and after that, the patient didn't came for follow-up, but she had very good relief. And the Goosey pills I am not using for these fibroids. And uterine artery
They won't work
embolization,
also.
uterine artery
Even progesterone,
embolization.
the new guidelines are saying that
yeah.
progesterone also won't work for fibroid. So we have other options available. Any other panelists want to add any other drug?
Yeah, actually, if the patient is asymptomatic, just strict follow-up. As it is around 4
She is
centimeters.
symptomatic, but symptoms are
Dysmenorrhea.
not very long.
First of all, let's put her on tranexamic acid.
Yeah, that's what. If she's having only menstrual bleeding, which is controlled with tranexamic acid, we can just try
Tranexamic
it.
acid.
Yeah, every month during the cycle, if she's very comfortable, follow-up scans every 6 months or 1 year. If the fibroid is growing fast, we have to think of using any medication like ulipristal or going for a surgery.
So, you know, for this person, I would want to keep her on a tranexamic acid and anamifenamic acid combination.
Okay. Then if fibroid is growing, and what next?
Yeah, fibroid is growing if the size is less than around 4 centimeters, ulipristal. If the fibroid is above 5 or 6 centimeters, usually ulipristal doesn't work, to my experience.
More than 4 centimeter, it won't work.
Normally, it doesn't work, and we should tell them. They usually think like.
What are the newer? What is the say of yours on newer molecules? Any panelist can add?
So mifepristone, like tried for 3 months, but I was never too satisfied with mifepristone.
Bleeding gets controlled.
No very promising results.
No reduction in size usually.
And ulipristal, I'm scared of using because there are a lot of evidences and some, a lot of guidelines which also say that don't use it for all its side effects also.
Yeah,
I don't
but
know.
strict guidelines are there to use uripristal. You should follow the strict
Now
guidelines.
they have come up with microwave ablations for all these things and they're beautifully working.
Another is a hysteroscopic removal of
hysteroscopic removal. If the size is bigger,
this
there
newer
are a channel
molecules
to reduce
like
the size.
Relugolix and Egagolex. Anybody have any practical experience of? Please add.
They all have been recently introduced, what I feel.
Excuse me, madam, it is Figo stage 3. So we
Yes.
can't do hysteroscopically, you have to do laparoscopically. 0 and 1 only we can do hysteroscopically. 3 is Figo stage 3 laparoscopically, especially if it is more than 4 centimeters, causing symptoms. And laparoscopy
Yeah, we can go for the
other
conservative
option, especially she want to preserve the uterus.
Yes, and ma'am, what I want to ask, what are the, when a patient is being treated medically, does the after treatment is over, does any patient revert to you with the same regrowing fibroid or the symptoms have recurred again? What is the incidence in that cases when medically treated?
Usually they come after 6 months or 1 year after stopping the medication with the same symptoms. Right? It works only for any medication, either mifepristone or ulipristal. Only we can control up to 3 to 6 months. If at all we want to do give again ulipristal, check the liver function test, and we can give it one more course.
Unless the patient and unless Dr. Nishi, the patient and the clinician both are absolutely lucky that she embarks on a menopause.
Yeah.
Yes, yes, that is
Even
there,
with the
ma'am.
MIFI, they are coming with amenorrhea if it is given.
These are all we are waiting for the menopause so
Menopause
that to
period,
avoid the
yes.
surgery.
Yes.
Yeah.
Now we can go on the medical treatment till she has her menopause. Otherwise, again, she will come back after a year or two
She will
with the
come
same
back.
size.
She will come back.
So,
So these are all the indications which create lots of many dilemmas. But yes, we have to judicially think about the options.
Right.
so I was searching for the guidelines and I got this new drug. I mean, it is from 2024.
Linzagolix.
Linzagolix, and they are
Linzagolix.
promising it a lot. And the important thing which I was searching about Europrostal acetate, and I got these literature that these are the contraindications or the recommendations from European medicine agencies that use of more than one treatment course is to be restricted to women who are not eligible for surgery.
So which means if this thing fails, then you actually embark on a surgery, right?
Yes, because ma'am, several literature was saying that this is a regulatory committee from European
know.
Medical Agency. They
Universal
say,
is not very safe.
yeah, they have said that they have revoked marketing.
Already it has banned in 2018 and then come back in
Come back, yeah. Then this
2021
was a
but the strict guidelines.
yeah. So this was the recent one that it has come back, but with strict guidelines to be followed.
Yeah, the European guideline says that even though with the close monitoring, when the patient is on ulipristal acetate,
Yes.
the liver failure is very sudden. So they ended up liver transplant and everything. So
yes.
those things are very scary to use ulipristal acetate. And results are not very good. I had seen patients coming with ulipristal acetate, started elsewhere and they complain only vaginal dryness and burning sensation in the vagina and all those things. Fibroid was not reduced in size at all. So this is my experience. I don't know. I'm not very happy with
No,
ulipristal.
it is there. There's no reduction of, I mean, very little reduction with Uripristal, even with mifepristone also.
Yeah, even with mifepristone, yes.
So I think the gist
the
is
latest,
that
what is your experience regarding the latest relugolix along with add-back therapy? Anyone can explain? So it is recently introduced by Sun Pharma people. I
Yes,
got
ma'am.
Yeah. Igagolix and this Relugolix introduced by Sun Pharma.
Relugolix.
One branch introduced Igagolix, another branch introduced Relugolix. Ma'am, abhi not having any practical experience yet.
Yeah.
Matlab mild. Others can add.
Me too.
Same here.
I think abhi to India mein it is not very much popular and not used much. So what are the crux is that we should wait for her menopause to come with some medical symptomatic treatment. Otherwise, conservative surgeries can do some wonders for her.
So uterine
She will
artery
move forward to
embolization.
the next
Anyone
category.
having any experience regarding uterine artery embolization?
Yeah, ma'am. So we have had a few patients who've undergone uterine artery embolization. Especially, this kind of fibroid is going to mess it up very badly because it tends to keep on, that discharge thing, it'll get autolyzed type of a thing, and then myolysis thing will happen. And that dirty discharge through the vagina, oh my God, it continues for months. It becomes very difficult. Once we've had a patient like very troublesome, bad experience.
Yes.
Especially, this is a type 3 myoma, it's going to bound to come out through the vagina. Difficult. And that becomes even more difficult to manage. Bleeding, you can still manage. How do you manage that lysed tissue flowing out of the vagina?
Yeah.
So
as such, we are using uterine artery embolization in cases of arteriovenous malformations.
yes, ma'am.
especially
Do
for
that. Yeah. But that everyone is.
only the indication what we are using that is the RPOC with high vascularity grade 3 and grade 4. Other
AV
than that,
malformations, the results are very
Yeah, for
good.
AV malformation we are doing otherwise.
The results are really good.
And for placenta percretas as well, ma'am.
Yeah.
But you know what I think is like the way for adenomyosis, this microwave ablation thing has come. This is going to good. This is very good for these type of small myomas also.
Okay.
And it's I mean, it's like microwave ablation is practically a zero learning curve for
Okay.
anyone
Have to
who's
go
TVS.
ultrasound guided and
Yes, yes.
Okay.
So very easy,
yes, ma'am.
right?
So I think for this patient, tranexamic acid will work, as said by Varuna ma'am.
It's
Other
going to be a
medication
savior.
we can try. Other medication also we can try and keep her in the follow.
Trenexa is going to be
Yeah.
our savior, basically.
Now moving on to case number 4, a 60-year-old postmenopausal woman is seen in clinic for follow-up after she underwent transvaginal scan for vague lower abdominal pain. The scan shows a simple unilocular cyst measuring 4 by 3 by 3 centimeter, and her RMI score is calculated to be 30. So should this patient be offered hysterectomy for the condition she is having?
No, simple follow-up is simple follow-up with ultrasound is sufficient when CA 125 and RMI are less.
Yes, ma'am. So we have to just counsel the patient that this is not cancer, and these cysts, if they are less than 5 centimeter, simply requires monitoring for repeat evaluation 4 to 6 months, and that is there. So what
Yeah,
now
can I add something, Nishi?
Yeah, sure, ma'am.
I think every gynecologist, because you are quite interested in ultrasound, and so am I. Every gynecologist who is doing TVS should be well versed with IOTA classification. So
Yeah.
when you know IOTA well, you yourself can assess the morphology of the cyst, put Doppler, see the color flows, see any papillary projections, and then grade the cyst. So automatically on the first visual inspection of that particular cyst, you can know whether this is looking suspicious or not.
Yeah.
So one preliminary test is in front of you or in the clinic only. After that, you can go ahead as the complexity of the cyst increases. So
Yeah.
IOTA is very good.
Yes, ma'am, and has to be followed. The guideline says that IOTA classification, because RMI is calculated on that basis only. So that is there. So the next question is, what change of treatment will be followed on follow-up if the cyst size increases to 6 centimeter with CA 125 still being in the normal range?
Yeah.
I
Still, I
request
like to wait. Actually, if it goes beyond or up to 10 centimeter, it can be done through laparoscopic cystectomy. Otherwise, even with the 6 centimeter, I like to wait and reassure the patient.
Okay, ma'am. Any other views?
Yeah, post-hysterectomy cases, I have seen one obese patient coming with the 8 centimeter cyst. I followed her nearly 6 years. There is no increase in the size of the cyst, and there is no change in the levels of CA 125. And she remained with the cyst for nearly more than 8 to 9 years, and no other symptoms except for the ultrasound appearance of a simple cyst. And finally, she lost for checkup follow-up after 8 years.
Okay, ma'am, but as the guideline says that if the cyst size is more than 5 centimeters, although it is showing, the size is increasing, but the CA 125 is within the normal range, that is RMI is less than 200, we can consider salpingo oophorectomy. Yeah, but no need to go for hysterectomy also in that cases. So it is just like removing the tube and the ovaries if the cyst size increases for more than 5 centimeters. But yes, when will the hysterectomy be justified? So if CA 125 starts increasing, then we have to look for malignancy, and we have to refer to an oncologist team and do a multidisciplinary review whether she needs, she must be needing staging laparotomy in that cases. So moving on to the next case. This is a woman aged 33 years, para 2 live true, with previous normal deliveries, presents with complaints of lower abdominal pain since 4 years after she underwent laparoscopic tubectomy. She has been to several hospitals for her debilitating condition and has received treatment multiple times for PID, and also has received a course of OCPs for 3 months. She also had undergone right ovarian laparoscopic ovarian cystectomy 2 years back, but her pain was not relieved, and her USG and MRI showed no significant abnormality. She thinks uterus to be the cause of this pain and is insisting on hysterectomy. So, ma'am, what is the diagnosis?
So mostly it is a case of chronic pelvic pain. So the cause is mostly adhesions in many cases, or PID, which is subclinical, or endometriosis, which is grade 1 or grade 2. Then adenomyosis, for which is not significant. So, and the most common in the women more than 40 years is musculoskeletal pain, I have seen. So, and
sometimes
UTI,
it might be,
one recurrent UTI following with the mild diabetes. Most of the patient will complain of low-grade lower abdominal pain and sometimes even low back pain also. So the counseling is more important,
Yeah.
and only relaxation therapy.
Because they
and
are coming
pain-
again and again with pain.
Yeah, yeah.
Varuna, you remember? Pedu Pirar. This is the word they use.
Yes, ma'am. So chronic pelvic pain is a dilemma, I think, for all the gynecologists as well, because we don't know.
And because of this pain, others are motivating them. कि आओ
Yes,
चलो hysterectomy कर देते हैं.
yes, ma'am.
तुम्हारी
That
बच्चे
was there with this patient. She was my patient, and every investigation which we used to do was normal. Even her MRI was normal. So we tried to look for the non-gynecological causes of chronic pelvic pain. And as madam had said, that it could be a musculoskeletal disorder, it could be irritable bowel syndrome, it could be recurrent UTI and cystitis, which we sometimes miss. And even the like local practitioners, and they also blame the uterus, and the patients want the uterus to be removed.
What about pelvic congestion syndrome, madam? I had come across one patient diagnosed with
Yeah, it
pelvic
is also
congestion
there. It
syndrome.
is there. It is there.
It is also there, and treatment is also very difficult.
Especially when the patient is having history of tibectomy. Your patient is having history of tibectomy.
Yes, ma'am, she was
Patient-
having, but
Yeah.
as madam said, pelvic congestion syndrome, we were also thinking. But the
Oh.
treatment for pelvic congestion syndrome is again ovarian suppression. And she already had taken overall L for several cycles. Still, her pain was not relieved. So, and in USG also, we couldn't find any finding of pelvic congestion syndrome, the dilated vessels and all. So that was
Dilated.
again ruled out.
Sometimes it might be deep endometriosis between in POD or prerectal space that may cause pain, which is get missed out with the MRI.
But
Yes, ma'am, you are very true.
all the
Because
other years, sometimes.
actually, thinking of that only, we did a diagnostic laparoscopy for that patient, and we found some adhesions in the POD and in the left adnexa.
Oh, okay.
So that was, as ma'am was telling, that there was a study where 26 women were studied for laparoscopic negative chronic pelvic pain, and their MRI showed injuries in the 20 women out of them showed injuries to the levator ani. So the point is that we should also look for non-gynecological causes when we are dealing with a patient with chronic pelvic pain. So my next question is, what is the role of diagnostic laparoscopy in chronic pelvic pain?
When nothing works out, we have to go for a diagnostic laparoscopy just to at least to satisfy the patient.
Yes, very rightly said, ma'am, because the guideline says so, that it is a second line investigation after the therapeutic interventions have failed. Like we have treated for PID, we have given her a course of OCP. If she is not relieved, then diagnostic laparoscopy will work to find the cause as well as play a role in developing women's belief about her.
Psychological relief also.
Yes, that she's having
And
nothing.
direct visualization is always better.
Yes, ma'am.
Depending on imagine.
Yeah. So that was the thing we did for her. So is hysterectomy the treatment modality? We have already discussed that psychological support has to be given to those patients, and we have to work in a multidisciplinary approach to treat such patients.
What about neuroanalgesics like gabapentin and all those things, ma'am? Anybody has got experience treating the patients with chronic pelvic pain with neuroanalgesics? Sometimes they get
works.
relieved with
So it causes
pulmonia.
more of sleep rather than pain relief, madam. And if they don't get enough sleep, they will get nausea next. They will be
Side effects are more, I think, with
Side
this.
effects of more. Okay. Yeah.
But
I
when
think we can give them a
at night,
non-pharmacological pain relief methods also, or manuals, and that may be also sometimes psychologically creates a lots of good effect. Non-pharmacological methods of pain relief.
Okay.
So in your patient, Nishi, you find mild endometriosis in the
no,
POD?
ma'am, they were just adhesive bands. There was no
Only
endo-
adhesive bands, okay.
Yeah, the just adhesive bands were
So
there.
you do some intervention also, like
Yeah, we just do some
relief.
adhesiolysis, and now the patient is discharged. She was feeling better, but she has not come for follow-up after the procedure.
We all know that in our gynecological OPD, we as a gynecologist, we are there to counsel them that yes, pain is surgery is not the solution for the pelvic pain, for a fear of cancer. But if they go they go to the other OPDs or with a non-gynec person, they interact with a non-gynec person,
Then
they
they
are
will come
motivated.
back to you without a uterus then.
Yeah, without uterus. So I think we are at the end of the panel.
Yes, ma'am.
So now I request each and every panelist to give one key messages for our
no,
good
madam. One doubt, madam. Patient underwent hysterectomy long back, about 5 to 10 years. They are coming with residual ovarian cyst, or when ovary is not removed in one or other side, they are coming with ovarian cyst of 5 to 6 centimeters in size, pain on and off. What will you do?
Ma'am, I think if the pain is more and it is 5 to 6 centimeter, and we see in the guideline also if it is more than 5 centimeter, we can go with laparoscopically. If it is highly painful.
We did the laparoscopy, but
I mean, I interact with the
in
two
4
patients who
cases,
came with a 7 centimeter cyst
4
after
cases, and the ovary is buried densely in
Yeah,
adhesion,
densely
very
adherent.
difficult to remove. Ended up with the complications of injuring the one patient had cecal injury, and one patient had ureteric injury, and in one cyst, we couldn't remove the cyst completely because it was completely buried in the pelvis under the adhesions. So whenever I get a ovarian cyst following hysterectomy, especially following open hysterectomy, I'm taking the help of surgical gastroenterologist bar surgical oncologist to open either for open surgery or laparoscopic surgery. 4 cases has 4 different complications for me.
That is true, madam. Retained ovaries developing cyst, it is very difficult to do laparoscopically.
Yeah.
Actually, we had also had the same experience, but it was very densely adherent. We changed to open method. So we avoided.
One case is densely adherent to the vault.
Yeah.
If it is an accidental finding, liming patient is not having any symptom, we leave it for the follow-up.
Yeah.
And otherwise, if the patient is symptomatic and
So whenever I see
we
ovarian
have to
cyst
remove
following
it.
hysterectomy from then onwards, see if the patient is not having any symptoms, I'm not touching the cyst. Just following the case with the CA 125 levels and regular ultrasound. So I had a difficult experience with the 4 cases. 4
That is
different
also
experiences.
Nowadays, even for postmenopausal women, they are saying that you can keep her on follow-up. I think some up to 4 to 6 centimeters. Five centimeters. Yes, you don't need to necessarily remove.
Madam is sharing for the symptomatic and 6 centimeter.
I know.
She's saying that it is
if it is symptomatic, then it is a problem.
Because इस तरीके के patient they are coming now, they go for lap surgery and now they are coming in few years after they are coming with the ovarian cyst, 6 to 7 centimeters.
And does progesterone has any role for ovarian suppression?
For ovarian?
I mean, will progesterone do any help in reducing the symptoms or size? It's just a thought.
No.
No, I don't think
No
so.
experience about it.
Yeah, no experience about that. No guidelines say that even OC pills sometimes it's not very helping. They say do not start OC pills just to reduce the size of the ovarian
The
cells.
guidelines is
Yeah.
not to intervene
The only
medically.
beneficial effect of progesterone or estrogen progesterone combination is on the endometrial level.
Yeah,
Not
for
that
the
the
hormone
Without uterus.
replacement.
Yes.
So I request all the panelists to please give one key messages for what we have discussed till now from your side
Yeah.
Doing
related to one
hysterectomy is
pathology.
very easy, but being ethical is very important, and you need lot of patience to counsel the patient and keep the patient under follow-up. So I
Yeah.
always tell my students also, obstetricians need patience. Like that, gynecologists also need patience. Patience in following up the patient, not doing unnecessary hysterectomy.
Yes, because we are trying to save an organ which the patient does not want to save.
Yes.
So we have to, any patient coming with the symptoms, we have to counsel them what are the modalities available for medically, and for follow-up they must come. So what are the complications, we have to explain them, especially following hysterectomy. Even though we do simple hysterectomy, there are chances of surgical menopause within 6 months to 1 year, most of the patients. So we have to counsel them regarding the post-menopausal surgical menopause. So in that way, we can counsel them.
Yes.
And we talk about maternal mortality rate. I was reading that in hysterectomy it is 0.4% the
Mortality.
Yeah, so if we talk like for 1,000 women, 4 women will die out of hysterectomy. So that is also a very large number.
Yes. And nowadays, many women are very obese. India is facing more
That
obese.
is an
And
epidemic.
yeah, epidemic. Obesity is becoming epidemic.
Obesity.
Post-operative complications are more when we do hysterectomies in on obese women. So that also a factor we have to take into account doing conservative management.
Explain the patient regarding the all the symptoms or osteoporosis. All these have to be explained if we are doing for a hysterectomy, and also counsel to preserve ovaries even if hysterectomy is needed. One more thing while counseling, as much as possible. And if the patient is less than 40 years, sometimes we are seeing repeatedly PCOS. Always do an endometrial aspiration or biopsy. Nowadays we are seeing more of young age endometrial pathologies also. And madam, one more thing in the chat, Dr. Sridevi from Vijayawada Society has asked regarding the disordered proliferation. Do we need to ask a pathologist? I think if at all any suspicion is there, we can ask for review or change the terminologies if we are sending for the same pathologist. Anyone has any opinion can tell me that.
And I think one more counseling, especially for the patient who are living in the remote area, that they always have to consult is Stri Rog Visheshak and the gynecologist for their complaint, not to any other doctor.
Yeah.
Yes. So thank you everyone. Thank
Thank
you.
you so much, all the panelists and Nishi and Monica Didi.
Thank you, ma'am.
Thank you so much. Shabana is like a regular in my program, and now Nishi has also made an entry. So Nishi, I'm going to trouble you again and again and again.
My
And
pleasure, ma'am.
dear friends, this was a very landmark webinar in which number one, so many reasons. The whole of South Zone was involved. Number two, Amey Purandre sir gave some very positive feedback about the fabric of Foxy and how we are helping spread that education. Number three, getting the key insight from a senior government official. Number four, getting to learn intricacies of robotic hysterectomy and hoping it comes under the reach of maximum government hospitals as well as good private hospitals, and learning a new technique. And definitely the case-based discussion by Nishi and Shabana was like icing on cake, and all panelists gave tremendous inputs. Even I learned such a lot. So you all are my Gurujan teachers. Thank you so much. And another announcement is for our next webinar. I just thought of this topic while I was listening to you all. The date is 8th of October. It is a Wednesday. We are doing Synergy episode 20. fetal medicine for the practicing gynecologist. How much of fetal medicine you should know, what are the mistakes you can make, when to diagnose, when to refer, what you can do, what you should not do, how much training to do, what fellowship to do, whether you can take it as a full-time job or you should make a part-time of it. So, thank you so much. Thank you, everyone. Thank you, Vishal.
Thank you.
One minute.
Dr. Monica.
Thank you, Monica. Wish you all the best. And thank you, Shabana, madam. Thank you, Nikki.
Thank you,
And
Radha.
thank you, Somalata and Tripura Sundari, madam.
Yeah,
And
thank you.
Umayil not joined. And Secretary of Kanchipuram Society also. Thank you, one and all.
Dr. Prabha Devi is so senior and she joined.
Yeah.
from
Thank you,
Bangalore.
Prabha Devi, madam. And
Very
Lata
much.
Venkatesh.
So
Yes.
Radha, wishes to you also, and see you very soon. Probably we'll meet in the Mumbai meeting. And
Yeah.
thank you so much, and have a very good night and an excellent weekend.
Good
Bye-bye.
night, everyone.
I have been
Thank you, ma'am. Thank you on behalf of Vijayawada Society for the opportunity.
Thank you so much, Dr. Lata. Keep
Yes,
synergy.
madam. I've been always been mistaken as Chitradurga president.
Okay.
So I request you to change actually the phone
Madam,
number.
madam,
I am
your
from
video
Chennai,
is not.
actually.
No, madam,
Yeah,
video
yeah.
is
I
not
show my
visible.
face. Yeah,
Lata ma'am, what is your designation?
I am a HOD private in a private institute at Sundara Medical Foundation, madam. I am from Chennai.
Okay.
Chennai, Anna Nagar. I am a HOD of the OG department.
Last time also we made the same mistake, no?
Yeah. But
Sorry.
anyway, I enjoy your webinars.
My apologies. My apologies.
Yeah.
Lata ma'am, please send your picture with your correct designation. We will save it in our file.
Yes, madam.
Because
Yes.
you are now a constant figure for our webinars, and we don't
Yeah,
want.
Monica, I want to give my CV, change it CV.
Yes,
This
please.
is old one.
Please do. Vishal, please keep saving the CVs. So, Vishal is my treasurer for CVs.
Okay.
Thank you so much. Okay.
Good night, everyone. Thank you. Enjoyed a
night.
lot.
Good night. Bye.
Thank you, madam. Thank you, Shobna, madam.
Thank you, Radha.
Thank you, Team Intas. Thank you, Vishal.
Thank you.
Bye. Bye.